There we go. Hello, everybody. Jill Osborne from the Interstitial Cystitis Network. It is Sunday, January 29th. It is time for another live IC support group meeting. This Sunday, we'll see. It's a very busy football weekend for many. So let us just see how the day progresses, shall we? My purpose in doing these meetings is to make you so strong, so knowledgeable, so informed that no one can mess with you again. I don't want anybody telling you that this is all in your head. I don't want anybody to tell you that you are damaged goods or that there is no hope, because it is absolutely not true. Hello, Boria. Nice to see you, hon. Hope you're doing well. I bring to you 3 college degrees. For those of you wondering what the hell my qualifications are, I'm the longest serving IC support group leader in the world now at this point in time. Certainly here in the United States at 30 years this year, my 30th anniversary. Yeah, baby. I have degrees in chemistry, drug development, pharmacology, psychology, and the IC network is my doctoral dissertation proposal to bring support to patients who were homebound. Ironically, I could not finish that because I was in so much pain I could not drive to school. It is quite comforting that 30 years later, it is still rated #1 in the world by Harvard Medical School, and I am published by Harvard. So I think we're doing okay here. Hello, Gay. Hello, Debbie. How are you today? Very proud of this work. Normally, when I do these meetings, I do a little 30-minute intro. Then I take your questions as long as you have them, and we just, play it by ear. I want to start. I want to start today talking about something that is just real. And that is the fact that your money is precious. Your money is very, very precious. And when I work with patients, I see patients, some patients get so desperate. You are willing to do anything. If Charlie over in this Facebook group says, take pumpkin seed, it'll make you better, you go buy it. If somebody over here says, take my class, I will fix you, you will get better. And before you know it, some of you have spent hundreds of dollars, sometimes thousands of dollars, doing things that in the end are not going to be helpful. We had years ago, and she's still around, a lady up in the Northeast who published a book saying she could cure your IC. And what was really amazing about that was that, and so a lot of people bought her book for $49, $50, $60, something like that. And all her book said basically was reduce salt. And so many patients were upset. And then again, we get back to that patient. I was working with somebody this week or last week who was probably doing 10 treatments at a time. And I'm just like going, yeah. And when you guys call me and we spend a little bit of time talking about your symptoms, what do I always say? I don't want to talk about treatments until we understand your anatomy. Don't tell me what you've done. I don't need to know what you've done yet. I have to understand. I have to try to visualize your body in my brain to try to make sense of things first, because you are an anatomical mystery to be solved. You are a pelvic mystery to be solved, right? And so here we've got this nice woman who just literally was just desperate. And she came on Facebook and she just tried everything everybody told her to do. And as a matter of fact, she's getting worse rather than better. And what's that old adage that, hey, if something isn't working, doesn't that mean that maybe you should probably step away from that and try something new? But what happens is we cling to comfort. That's why I was working with yet another patient who invested her entire life savings in Elmeron, this sweet elderly lady. She was like from Indiana years ago. She had no money left. She had spent it all on Elmeron. And I asked her, I said, well, did you get better? And she went, no, it never helped me. And I said, then why did you keep buying it? And she said, because there was nothing else. Okay. We're past that now. We're past that now. Now we know why Elmerin doesn't work for a lot of people, because for a lot of you have a healthy bladder wall. Your symptoms are being caused by something else, right? So I need you to be very good consumers credibility checkers here. There is no reason for you to be spending hundreds, if not thousands of dollars on stuff you hear about online. You need to ask, come to the credible sources. The IC network, the ICA. You don't have to pay to take a class on IC. I'm giving you that class for free right now. So my heart breaks I was working with a patient who was just desperate. She was trying everything. She was out all of this money. And in the end, so she had done all these bladder therapies, and the class that she was taking was telling her, reinforcing the concept of bladder stuff, right? And her bladder was healthy. They looked at her bladder. Her bladder was completely healthy. It was her pelvic floor. It was her pelvic floor. And I said, hon, you need to put that money into pelvic floor therapies. You know, the physical therapist said your muscles are locked down hard, tight. They're like rocks. That's where your money needs to go. And she said, she was like, oh, I never thought about it that way. You have to start thinking about it that way. You know, we, for those of us who have worked in IC for many, many years, our goal is to educate you. Our goal is to help you. Our goal is to stand beside you. Our goal is to encourage you. Our goal is to comfort you. Our goal is to kick you in the butt when you need to be kicked in the butt to get back to the doctor, right? But I have never, ever, ever charged for these live support group meetings, ever. Why? Because I know a lot of you can't afford it, and that's fine. That's fine. 95% of the IC network that we do, we give away for free. The only thing we charge for is our magazine, okay? So I just want you to be good consumer activists here. Stop believing some of these crazy claims you're hearing online. And when you're thinking about investing your money, you have to ask yourself, how will this help my unique case? Because there's no one size fits all solution here. We're all different. And that's why Facebook groups in the end are flawed, because you can't put apples, oranges, and bananas in the same study and expect them to behave the same. You can't put a Hunner's lesion patient, a bladder cancer patient, or cystitis patient, an estrogen atrophy patient. You can't put all of those in the same support group and think that you're going to have commonalities. For all you know, you're talking to a patient with severe Hunner's lesions, or you're talking with a patient with estrogen atrophy, or you're talking to a patient who refuses to give up coffee, right? So I just get frustrated because literally this is a master class in IC right here, right now. This is the master class on IC on the internet right here. And it's free. So please use it and tell your friends about it. Okay, can you send me the link to our magazine? Yeah, sure. It's on our, if you go to the IC Network website, just go to icnetwork.org, and it's in the news pull down menu, right? Just in the news pull down menu. I get frustrated because I'm the person picking up the pieces with that person who calls, who's already done everything else. and it's like, oh, please stop, take a breath, take a step back. Okay, tell me, when did your symptoms start? Okay, I was 20 years old, 21 years old. Okay, was there any event that you associated with the onset of your symptoms? Yes, I had a baby. I was never the same after having a baby. Okay, so what happened during the delivery? Oh, I had a terrible tear. I tore all the way through to my rectum. They had to surgically put me together. And that's when my bladder symptoms started. Okay, big giant clue, right? That is what we call an injury patient. That's a trauma patient. And so you spending a lot of time working on diet and all this other stuff is rather pointless. We have got to work on understanding the muscle injury, right? And again, in that patient's case, what was interesting was she was sleeping through the night. What she had was pins and needles. What does that mean? That means that nerves are involved. Why are nerves involved? Because obviously, and in her case, she'd had 2 babies. The first was terrible. Oh, and even worse, her incisions. Now, I got talked to so many patients, I sometimes get them confused. No, that wasn't her. That was somebody else. Okay. So anyway, she's had 2 children. The first was catastrophic with respect to a muscle injury. I remember in high school, the biggest teaching moment for me ever in high school was Mr. Jim Johnson, who said, the greatest gift that a woman can give to a man is to risk her life to bear his child. To risk her life to bear his child, because carrying a baby and having a baby is dangerous. And young mothers die, but young mothers get injured. She got injured at like 20, 19, somewhere years old. Then, because her injury was so bad, she suffered a prolapse. Then she had a vaginal lift. Then she had a urethral lift. Nothing got better. Then she had a hysterectomy. That just made it worse. Then she had her ovaries removed. We're talking trauma, 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 trauma. And again, it's pointless to pay attention to do all this diet stuff. It's pointless right now. That's not going to fix anything. What's going to fix it is understanding the anatomy. Does that, am I making sense here? Do you guys kind of understand what I'm talking about here? Her money needed to be spent with physical therapy. Okay. I want to say more, but I hope I'm trying. I hope I'm being clear. So the other big project of the week is I got the blog up on the new 9 subtypes proposed by Curtis Nickel. So I did my drop-in meeting 2 nights ago here on Facebook, but now we're on YouTube too. And so I want to go through that again, because this yet proves how we are so different. But he brings up a couple of things we never thought about before. So hold on one sec. Let me so I am going right now to the front page of the IC Network website, icnetwork.org or ic-network.com. And it's our first blog under research. So let me just kind of go through this a little bit, because you have, here's the other thing. In fact, I was exchanging email with a couple of the top doctors this week, and like Curtis Nickel, they're retiring. They're getting ready to retire, and they are trying to motivate the next generation of doctors. The problem is the next generation of doctors are not as enthusiastic as they were. And so we have to create that enthusiasm for them. And as I posited back to them, it's like, okay, you are forgetting one very, very powerful mechanism of education, and that is patience, because we go to every doctor. So if your doctor doesn't read your article from the Canadian Journal of Urology or from the Journal of Urology or go to the class, that's okay, because we're going to give those patients the best articles we can so that they can bring them to every doctor they see. And we're going to do grassroots education from the patient up the chain to the doctor. Instead of top down, we're going bottom up because we have a hell of a lot of power that we need to be using. Alexa says here, I started having pelvic pain and something that felt like a UTI back in July. Thank God I was led to you. You told me right away it was menopause. There are no damn tests for this. No, Alexa, because menopause is eyeballs. It's just looking at your vulva. You know, if your symptoms start after hysterectomy, if your symptoms start after having going through perimenopause, menopause, or you're on Lupron, something like that, the very, very first thing we have to consider is estrogen atrophy and the quality and health of your skin. Many women are very confused because in your 40s and 50s, when these symptoms start, you're going UTI, 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 but your cultures are negative. So what the hell is it? And then somebody goes, well, you have this incurable bladder disease called IC, which pisses me off. And it's like, no, you don't have an incurable bladder disease. There's no bladder disease found in IC. And in fact, that's what our guidelines say now. What you do have is a skin issue. The loss of estrogen reduces the health of the skin. It makes it more difficult for the skin to protect itself, right? Estrogen atrophy, genitourinary syndrome of menopause. That's a big chunk of the female patients with IC, but it's not the biggest chunk. The biggest subtype is pelvic floor. So anyway, let me go through, I just want to go through these new subtypes, because this is what we're going to be using from this point forward. Samara on Facebook says, can you lose control of your bladder with IC sometimes? Not usually. IC is not strongly associated with incontinence unless you are of an age, getting back to estrogen and loss of estrogen. In addition to skin getting drier, muscles get weaker. And so it's quite common for women as they get to be a wee bit older to start having a few control issues. If you startle me, if I fall down suddenly, I had a dog attacking my cat years ago. Man, I am punchy today. Anyway, I fell chasing after the dog, and that was the only time in 50 years I'd wet my pants. Just bam, it was empty. So Samara says she's 50. You definitely want to talk to your doctor about it, because incontinence relates to nerves perhaps not working correctly, but it can also relate to muscles that have gotten weaker, and it can relate to just GSM. So make sure you mention it to I would start with your gynecologist first. I'm not particularly worried about that. I mean, if you had no control, that's a really big issue. But they need to look at your pelvis. They need to look at your muscles. We need to try to figure out what could be going on with that. All right, so let's go this. For more than 30 years, newly diagnosed patients with IC were given bladder meds with little, if any, success. Why? Researchers and clinicians believed at that time that IC was an incurable bladder disease. But today, that perception has changed dramatically. Our updated 2022 guidelines for IC very clearly state that no active disease is found in the vast majority of patients. They now believe that patients are struggling with a pelvic pain syndrome driven by dysfunctional nerves and/or muscles. For the patient, though, finding the correct treatment for their unique case of IC is challenging. Phenotyping helps you find the most effective treatments. For the past 6 years, we've embraced a system proposed by Dr. Christopher Payne. He believed that there are 5 core patient groups, each requiring their own treatment, including Hunner's lesions, bladder wall-driven, pelvic floor-driven, pudendal neuralgia, and central sensitization. Yet in his proposal, he also suggested that there could be more. Remarkably, the AUA guidelines now also recognize that there are at least 3 distinct patient groups. They put Hunner's lesion, a bladder wall, and in bladder wall, they combine all the bladder wall issues, pelvic floor, and widespread pain. And of course, our own National Institutes of Health now openly acknowledges that the reason why IC studies failed for the last 25 years is because they mix the patient groups. You cannot expect a patient with Hunner's lesions and a patient with bladder wall estrogen atrophy versus pelvic floor versus widespread pain to respond the same way to treatments. They simply won't. So from this point forward, the big debate now at that international level is, okay, how do we do it? Do we subtype before the trial begins? Or do we subtype after the trial is completed. I think that that's rather stupid. I think it's very important that we give researchers an early on-ramp to success. We got to get them motivated. We got to give them encouragement. And so if a patient, if a researcher is studying a bladder wall therapy, then they need to be pulling from the bladder wall group, not the pelvic floor group. If a research team is studying how to calm nerves down, then they need to pull from the central sensitization group, not the pelvic floor group, right? Right? Okay. I think asking researchers to do the subtyping afterward, it's too much work for them, and it will not be a good study. And what have we learned in the last 25 years? It's just not a smart thing to do. Some doctors believe it is. I don't think it is. Okay. So Dr. Curtis Nickel, the preeminent IC researcher and clinician in Canada, offers a new proposal of 9 subtypes found within the IC community. He wrote, quote, "I have been asked by urologists many times over the decades how to treat a specific patient with IC and found that I gave a different answer based on each patient's clinical picture." He has also found that a stepwise monotherapy approach, which is one treatment at a time, is doomed for failure in the majority of patients. Now, understand that Dr. Nichols' credentials are impeccable. I mean, like literally, he's in the top 5 in the world with IC, probably the top 3, maybe even the top 2. He's conducted 24 clinical trials. He's done 200 IC studies. He's written over 600 publications, and he's a brilliant writer. He's presented courses in 45 countries, and obviously he's worked with hundreds of patients over the years. He's also the former president of the Canadian Urology Association. So Dr. Nickel uses the concept of a recipe to describe a patient treatment plan. Each recipe begins with some common ingredients. He encourages patients to be willing to learn about IC and to be proactive with their diet and exercise. Eliminating foods that are known triggers is an easy first step. And to trigger the production of endorphins, low-impact exercise are suggested with a caution about exercises that put pressure on the perineum, such as biking. He also encourages positive mind exercises like positivity and mindfulness because we know that will help in healing and improved outcomes over time. To physicians, he reports using DMSO and Elberon less frequently due to the short and long-term risks, such as retinal disease. He encourages the use of pain management early in all patients, including NSAIDs, acetaminophen, urinary analgesics. Now, he and I disagree on this point. He believes that long-term use of opioids should be avoided because they restrict the body's own natural opioid production and fail to provide pain benefit over time. However, he notes that the strategic use of cannabis seems to help patients cope better. Now, speaking as a former severe pain patient, I think that there is a place for opioid use, just like the AUA does in their guidelines. Dr. Nickel wrote, "It is imperative the pain outside of the pelvis associated with IBS, fibro, chronic fatigue, back pain be managed. Pain left untreated acts to upregulate the nervous system, making it more sensitive to pain. This may require multiple specialists, including a urologist, gastroenterologist, OBGYN, etc. And surgery is the very last result, and only for patients who have tried all other therapies with no success and or have an end-stage bladder. An end-stage bladder has lost its ability to expand to hold urine and is fibrotic, like scar tissue, thick, unbudging." Now, here's something he did that I don't know of any other urologist is doing. Every Friday afternoon, he has a rescue installation clinic, and he notes that many flares seem to happen right before the weekend. And so to help those patients get through that flare, he has a nurse do bladder installations every Friday afternoon. You can just call, say you need an installation, you get in there. That's wonderful. That is absolutely wonderful. Cindy said, "Is it possible to have Hunner's ulcers and not have them cause pain?" Yeah, once they've healed, they turn white, and they usually don't cause pain after that point. Hold on a sec. Alexa, I will get to that in my next thing. Alexa wants to know how chondroitin helps. And yes, it does help your urethra too. Okay, so let's go through his 9 subtypes. Again, because this is what we're going to be using from this point forward. Number 1, inflammatory IC. This subtype has patients who have Hunner's lesions or visible inflammation on the bladder. If that patient does have Hunner's lesions, you should be cauterized immediately, multiple times if necessary. And then he transitions over to steroid injections, triamcinolone injections into the lesion, not to exceed 80 milligrams. Now, this is something he does that I don't know of a lot of doctors who do. He says for mild Hunner recurrence, or for early Hunners, that's when he might use a rescue installation. I haven't really, kind of the word on the street is rescues haven't been particularly helpful for severe Hunners, but I think what he's saying is, hey, but they might be helpful for mild Hunners. And for patients who do not respond to treatment for their Hunners or their inflammation, this is where oral cyclosporin truly shines. So this is the only context where we're going to use cyclosporin, is for inflammatory lesion, inflammatory conditions on the bladder and or Hunner's lesions. For all of us, cyclosporin else is off the table. Okay, number 2 is a new subtype, infection-mediated IC. So none of the other doctors have acknowledged this as a patient group. Generally, at least here in the United States, if you've got positive UTI, a positive urine test, you are excluded from a diagnosis of IC. But he says that patients who have a history of recurring UTIs may be experiencing what he calls a bladder hypersensitivity syndrome secondary to the infection, that the bladder wall, the nerves in the bladder wall become extremely sensitized because of that recurring damaging infection. He also says that while long-term antibiotic therapy is an option, he suggests putting antibiotics directly into the bladder in a bladder installation. That makes more sense. That way, 100% of the antibiotic arrives exactly where you need it, in your bladder wall, right? Or at least in your bladder. And then also just know that he was one of the early researchers with the new UTI vaccine, MV140, and that's getting rave reviews so far. So wouldn't it be great if we can all have, even though I know vaccines are a bit of a dirty word, they're not a dirty word. Vaccines help millions of people survive. Can you imagine having a vaccine that could prevent a bladder infection? Wouldn't that be amazing? Well, they're working on several forms of that right now. Okay, so for that patient with recurring UTI, we're going to look at antibiotics directly in the bladder wall. Our third subtype is the widespread pain central sensitization subtype. He calls it neurogenic hypersensitivity. Just means that the nervous system has become remarkably sensitive and traumatized. We call this hold on, what word am I looking for? A central nervous system maladaptation. You know, it just got really windy. And I've got these redwood trees like right here, and that distracted me because, we're always worried these redwood trees are going to fall. So if it gets really, really windy, we'll see what happens. Okay. So for patients who have widespread pain central sensitization, they're the ones who seem to respond the best to a low-dose antidepressant because antidepressants calm nerves down. They're not giving you an antidepressant for depression. They're giving you an antidepressant because it helps to stabilize and calm the nerves down. And that will help reduce some of your pain. Okay. And also, again, for that sensitivity in the bladder wall, a rescue installation makes sense here. Now, here's another new subtype, allergenic IC, multiple allergies. For those of us who have respiratory allergies, environmental allergies, and dietary allergies, there is always a chance that we have got that allergenic process happening in the bladder wall. And he says, there's a way for you to identify that. And so, and I've never heard any doctor say this before. So he says, this can be easily identified during a cystoscopy by gently poking the bladder wall with the tip of a flexible cystoscope. They're just going to tap the bladder wall. They're not banging it. They're just tapping the bladder wall. And if the location that they touch turns red and develops what we call a wheal, W-H-E-A-L, that's an allergenic reaction. So he says for patients who develop that red bump after touching the bladder, that's when we're going to look at hydroxyzine and antihistamine as a viable treatment for you. And you know, I go back in my history, right? Because I was diagnosed with IC when I was 31, but I had my first symptoms when I was 14. But I have a lot of allergies, a lot of environmental allergies. And while bladder treatments like DMSO did nothing for me, I will say that hydroxyzine was quite helpful for me for many years. Why? Because it was just calming all of my allergies down. My allergies do not, I believe, cause my IC, but they were certainly exacerbating my IC. Okay, his subtype number 5 is our biggest subtype, pelvic floor driven. 85% of IC patients, according to the latest study, have tight pelvic floor muscles. 85% of us have issues with our muscles. And of course, I call this the chicken versus the egg dilemma. Which comes first, the chicken or the egg? And for us, it's which comes first, the bladder or the pelvic floor. For some of us, this begins with a bladder wall issue like chemotherapy. And because your bladder's screaming in pain from the chemicals of the chemo, your muscles get tight. So that muscle tension can be a reaction to pain. But for far more patients, it begins first with a muscle trauma, like having a baby at the age of 20 and suffering a severe muscle tear. Believe me, that's going to create issues. And then because the muscles are so freaking tight and they've been tight for so long, you are now ischemic, poor blood supply. Is the bladder wall going to be healthy if it only gets half the normal amount of blood it's supposed to get? No, it's not. So for these patients, of course, you have no idea you have a muscle issue. Your first symptoms, frequency, urgency. You think UTI, you go to the doctor. Doctor goes, okay, let's do some antibiotics. They don't work. Go back to the doctor. Doctor does urine tests. Urine tests come back negative. He says, well, let's just do long-term antibiotics anyway. They don't work. Go back to the doctor 6 months later, a year later, 2 years later. They go, well, maybe you've got overactive bladder, which is a neurological issue. They give you overactive bladder meds, bladder antispasmodics like ditropan or Detrol. They don't work. You're still flaring. You go back to the doctor goes, I hate to break it to you. I think you've got this incurable bladder disease called interstitial cystitis. Here's some Elmeron. Here's a diet. I'll see you in 6 months. And you legitimately want to get better. So you do everything they tell you to do. You follow the diet. You take the Elmeron. But the problem is you're not getting better. You're still flaring. You're still having many, and some of you have gotten dramatically worse. You might do that for 6 months. You might do that for a year. You might do that for 5 years. You might do that for 10 years and never get better. Why? Because bladder therapies are not going to fix tight freaking muscles, and nor are bladder therapies going to restore proper blood supply. Our therapeutic priority is to restore blood supply. The way we do that is with pelvic floor physical therapy. And as Dr. Nichols says in his article, it is imperative that pelvic floor physical physiotherapy be undertaken by specialists trained in pelvic floor manipulation. If you go to a physical therapist and they tell you to do a Kegel, they are not trained. Kegels are the worst thing you can do when you have tight pelvic floor muscles. And you're never going to figure this out on your own. If you know, and I know that some of you do not. You're going, no, I don't want anybody touching me down there. I understand that, especially if you've been abused. I completely understand that. And I am sympathetic to that. And I am compassionate to that. But there's a lot of muscles down there. It's mirrored. You got muscles on the left side, muscles on the right side, right? They're mirrored because they connect at the tailbone and at the sacrum. You've got muscles that are shallow, muscles that are medium, muscles that are super, super deep. So if you have sciatica, that is a de facto diagnosis of tight pelvic floor muscles. That's your piriformis muscle. If you have piriformis syndrome, like I do, that's your piriformis muscle. If you have pain with intimacy, pain with penetration, the odds are that's a tight levator muscle. If you have pain around your rectum, pain with bowel movements, pain with urination, or you're straining, or you can't start your urination right away, that's levator muscles. So ideally, if you can, let's just say, again, we started this meeting talking about money and lack of money. Okay, I understand that. If there's any way you can just save up for one appointment, just one appointment, 150 bucks. If there's any way that you can do that, we just need somebody to study your muscles to tell you where to start, because you'll never figure that out on your own. Never. And there's no supplement that's going to pick your pelvic floor. And diet modification is not going to change your pelvic floor. What's going to change your pelvic floor is working directly with muscles. And I think it's very important that we just be very honest. And when you go to the physical therapist, and in some states, you can even self-refer. In California, I can go to physical therapist 10 times without a doctor's referral. That might be possible in your state. But the goal is to get a second set of eyes on your pelvis to try to see if there's anything weird going on. Then it's very, very important that you tell them about trauma. You know, what do I always say? Don't walk into a new appointment and say you have IC. That's pointless. You're going to fall down the rabbit hole of IC. You need to walk into that appointment and say, you know, I get this weird vibration when I sit down, which I'm actually having right now at this very moment. My left butt cheek is starting to vibrate because I tweaked those muscles and nerves this week. Or I get pain that shoots down my leg. Or I can't urinate right away. I sit and hesitate. Or it feels hot. Your ability to describe your symptoms gives that physical therapist a roadmap. And most importantly, what were your sports? I was working with one patient who was a power lifter. And I asked her, okay, when did your symptoms start? Well, she had an accident powerlifting. And she knew that she had damaged her tailbone area, her pelvic floor. She had pain for days afterwards. That was the start of her pelvic floor dysfunction. I have no doubt about that. Have you had children? Have you had surgeries? Do you remember any falls? Anything at all like that? Let's give that physical therapist a roadmap. Okay, so his sixth subtype is, and I honestly, we've never used this consistently, primary storage symptom syndrome. So basically what that means is that patient's daily life is controlled by frequency urgency. If you're running to the restroom to reduce pain, because you know that the fuller your bladder gets, the worse you feel, that is IC, but he's defined that further as primary storage symptom syndrome. And so let's see, and he calls frequency urgency kind of a learned behavior. That's not the word he used in the article, but it was something like that, where it's just the direct result of pain. So if you're somebody who, being on a plane, that's a perfect example. So if I have to get on a plane, I pee before I leave the house. I pee when I arrive at the airport. I pee right before I get on the plane. I get on the plane. I pee before the plane takes off. I sneak in and get in there. I always pick a seat next to a bathroom, even if it's the last seat in the plane, so I can do that. As soon as the plane meets altitude, I pee again. As the plane is beginning its descent, I pee again. I get off the plane, I pee again. That's real. That's completely real. That's me every time I fly. Some of that's a stress response because I don't like flying, but That's also a learned behavior on my part to avoid pain. So he says in these cases, we would benefit from an anti-muscarinic medication like sulfenacin. The problem with sulfenacin is it doesn't do anything for pain, and it's very important that we nip that pain in the bud. And so he recommends mirabegron. Mirabegron, mirabegron, mirabegron. Because mirabegron calms nerves down and reduces pain. And the advantage also of mirabegron as compared to ditropan or Detrol is that it's not an anticholinergic and it will not be linked to dementia. So mirabegron is great. Unfortunately, it's a little bit more expensive. He also said that bladder training is essential for this group because you basically trained your bladder to kind of get smaller and smaller because you're not going as often. You're not allowing your bladder to hold more urine to stretch. And so doing a bladder holding protocol makes sense. So a bladder holding protocol just means that if you pee every 20 minutes, he's like, okay, go to 25 minutes for a couple of days. See how you do. Go to 30 minutes. See, and just slowly and gently increase your bladder capacity. But don't hold it for an hour right away because you're just going to trigger the nerves. It's got to be a very slow and gentle expansion. Okay. Also in this group, sacral neuromodulation. So the only context where he mentions inner stem is with this subtype. Now I have to wonder, to establish a diagnosis of that, would he have to do a urodynamics? I don't know. He didn't talk about that in the article. Okay. Subtype number 7, urethral pain syndrome. This is also a new subtype. So these are the patients whose symptoms are dominantly urethral in nature. Yeah, you might have some bladder issues, but it's the urethra that is the hot spot. And he flat out says he finds this a very difficult group to treat. He's going to use topical lidocaine, vaginal estrogen if we've got some estrogen atrophy going on. So low-dose antidepressant to calm nerves down, some pyridium to numb the nerve surface of the bladder, Valium, and maybe even a periurethral block, a nerve block. Okay, so that's interesting. We don't really see as much. I mean, I've had a couple of patients call us who suffered with severe urethral pain, and I think one story is absolutely worth sharing because this is a woman who had been diagnosed with IC for over 10, 15 years. Bladder therapy has never helped her. And she sees many doctors. She's 5, 6, 7 doctors. And she's like, it's my urethra, it's my urethra, my urethra. And they kept going, no, it's your bladder, it's your bladder, it's your bladder. Finally, she goes to a new clinic where she sees a nurse practitioner. And the nurse practitioner listened to her. And the nurse practitioner said, okay, let's do a CAT scan. Let's see if there's anything wrong with your urethra. They do a CAT scan and they found it. They found it. She had a fistula. A fistula is a pocket. So if you strain really hard to urinate, you're putting a lot of pressure on your urethra. If there's a weak spot, it's going to push out. Well, in her case, she had a giant fistula. So your urethra is about the size of your little finger. Her fistula was as big as her urethra. They were connected by a little tube. So what was happening is urine was collecting in the fistula and causing massive infections and all sorts of, it was just very, very bad. So when they surgically removed the fistula, she was cured. Now imagine, she was told she had an incurable bladder disease when it wasn't her bladder at all. It was a fistula. And what do we always say? Straining is bad. Never strain. You should not be straining at all. If you're straining, that tells us that there's a problem. All right. His 8th subtype is sexual pain. Pain with intimacy must be addressed with patients who are sexually active. The location of the pain must first be assessed. So that's a challenging for many of you is, okay, it hurts with sex. Where? Is it in your vagina? Is it in your vulva? Is it your pelvic floor or your bladder? We have to figure out where the pain is first to treat it. And that's where you got to be really thoughtful and really think about it. Where is it? You can't just say down there. It doesn't work. And so for this group of patients, it's dominantly pelvic floor physical therapy combined with lidocaine to calm nerves down, combined with estrogen to improve vaginal skin health. And then the last group, his group, he calls flares its own subtype. He argues correctly that a patient in a severe flare needs more care. But we have to figure out what's causing the flare to give you the right care. So a flare can be triggered by diet, that's a bladder wall flare, by menstruation, by stress, other infections, inflammation, intimacy, long car rides, traveling, etc. And so that gets right back into our own flare management plan. And for those of you suffering with flares, come on over to the IC Network website, sign up for our free newsletter, and you can download our 40-page flare management guide for free. Let's see. So what's our conclusion here? You, the IC patient, play the most important role in making these changes happen. So here we've got the best and brightest minds leaving a legacy. They're leaving great resources and tools for us, for the next generation. But will these tools get to that local urologist in your town? No. No. Your local urologist is not going to come to a meeting and take a class on IC. Now, if you happen to run a support group, one thing that you can do is you can actually sponsor a grand rounds class. We get a lot of doctors who will take grand rounds. You do them on Friday, give them lunch, you can tell them anything. But for the most part, these brand new tools and guidelines are not going to get to your local doctor unless you bring them. We need you to bring them. We are the educators. We have become the educators here. We're going to give them enough to tantalize their interest with the reference to go, here's the journal article, check it out. We just have to get them involved. And some doctors love that. My old urologist, Dr. Klein, loved it when I brought him stuff. He said, I taught him more about IC than anybody else ever had. But then other doctors are too arrogant and they don't want to read anything, even if it's a journal article. So I'm really, really excited about the future. We have got this fabulous, fabulous new resource. We are going to help so many more patients. You are going to help patients. So as you are online in support groups, you need to link them to this article. Please link this article into your groups. I'm going to, here on Facebook, I'm going to give you this link. And here on YouTube, I'm going to give you that link too. Would you please share this everywhere? Oh, darn it. The Eagles are ahead 21-7. And it's, oh, man. Oh, come on, Niners. Come on, Niners. You got to do this. All right. Oh. We've got this fabulous young quarterback, Brock Purdy. All right. So here, YouTube. I'm going to give you the article, the link to this article here. All right. There you go. All right. So let's get back to some of your questions here. Heggy, thank you for the 100 stars. Much, much, much appreciated. Heggy says, I have a lot of allergies too. So do I. I just rubbed my nose. I mean, listen, our spring season here in California is starting. Even though it's cloudy and windy today, we've had a week of 60s and 70s, and the mustard is blooming, and the acacia trees are starting to bloom, and this is the worst part of allergy season for me. Michelle says, I've taken Elmeron for years. It works, but since that lawsuit about vision, I stopped taking it. I think that, Michelle, that was wise on your part. I think that that was quite wise. It is heartbreaking that our only oral FDA-approved therapy for IC, which thousands of patients have taken, has now been linked to potentially very severe retinal disease. It's called pigmentary maculopathy. And I can show you a picture of it. Here, hold on. I've got some new, I've got a lot of new things I can show you guys. Here you go. Well, listen, okay, this is not the eyes, but this is cool. So we have a new atlas that was published showing what Hunner's lesions look like. And actually, let me do this one first. So you see that the red spot in the middle here, red spot here, red spot here, red spot here. That's really a classic lesions. And lesions are known for bleeding profusely. They call it a waterfall. So you can see that right here. You see this bleeding right here. So they call this a coagulum. It's just it's like a blood clot, coagulated blood. Okay, so classic Hunner's lesions with a coagulum, and then these are Hunner's lesions without a coagulum, right? Okay. Okay, this one's interesting. So here are lesions, the first 6 that are bleeding. I mean, listen, if you have somebody in your family who is not sympathetic to your struggles with Hunner's lesions, you just need to show them this freaking picture. This is what my bladder looks like. This is not healthy. This is bleeding. And then these bottom pictures are healed lesions. See how it's white? Oops, that's a good one. So those bottom pictures are healed lesions. Okay, here's another picture. Now, y'all remember back in the old days, they used to say that petechial hemorrhages were IC. They used to believe that these little red dots, they thought this was IC. But no, this is also thrown out because when you stretch the bladder, this happens. This is what healthy tissue does when you stretch it. It rips and bleeds. So that finding of petechial hemorrhages on your bladder wall, meaningless, thrown out in our latest guidelines. Lori says, can you heal Hunner's lesions without surgery? I think what you're asking is, can you treat a Hunner's lesions without having an outpatient procedure? And the answer is no. The best therapies, according to research for Hunner's lesions, are lesion-specific therapy. When you touch the lesion, so you can cauterize the lesion, or you can inject it with a steroid, or now here's something that's not surgery. Hyperbaric oxygen therapy has been found to be somewhat helpful for patients with Hunner's lesions, so that's not surgery. But there's no cutting, there's no incision involved in the treatment of a Hunner's lesion, unless, I mean, in the old days they did that. In the new days, they don't resect lesions out unless it's just a very persistent bugger that is not responding to anything. Then they might try to cut it out. But bladder wall surgery is not normally done for Hunner's lesions. And as Dr. Nichols said in his guidelines, if they're very mild lesions, you could perhaps try a rescue to just try to calm the nerves down and calm everything down. Tia says, any supplement recommendations for a 30-year-old female who believes her pain is caused by low estrogen? Yes, chondroitin. Chondroitin. The most important ingredient is chondroitin. Chondroitin is essential to the health of the bladder wall, the superficial integrity of the bladder wall. Bladder Builder is, in my opinion, the best supplement on the market. You can see it on my shelf over there in the dark jar. So I rate it bladder builder, bladder rest, cystomend, and cystoprotect. But really, bladder builder has more ways of potentially helping because it's got chondroitin for the bladder wall. It's got quercetin as an antihistaminic effect. It's got beneficial probiotics for the gut. It's got essential amino acids. But most importantly, it has PEA in it for pain relief. That's why it is the most comprehensive formula. However, if you flare when you eat yogurt, if you flare when you take a probiotic, bladder builder's off the table. I would be doing cystomend or bladder rest. Okay, let me get back to this eye thing. Sorry, I get distracted very easily. Can you tell that? All right, hold on. It's not that file. Freebies. It's not that file. Anyway, 6 steps. Got to throw that out. We don't do 6 steps anymore. I'll just put that in the trash right there. Pain subtypes. Yeah, we're keeping that. Bladder images. All right, come on. Where are my eye images here? Where are they? You realize all the work we're gonna have to do now. I have to rewrite our book, IC 101. Okay. Yep, this is it. Where's my picture? Here it is. Okay. So getting back, look at this. It's all, my hair is all weird. I wash my hair, but it's all fuzzy now. In fact, let's just put it in a ponytail. Okay. So let us talk about what they have seen with Elmeron and eye disease. So this is from the first article that was published by Dr. Jane and his colleagues at the Emory Eye Institute. Now, it's a very interesting story. They were referred, basically a bunch of young patients, well, young and older patients who all had this weird eye thing going on. And eye institutes, their job is to rule out genetics, rule out every other disease. And in the end, for this group of people, the only connection that they could make is that they all used Elmeron. And so this was their first paper. Now, there are many papers now. We have a whole website developed dedicated to this. So anyway, let's see. This is a better picture. So Elmeron, well, the bladder is composed of, has GAG layer, the glycosaminoglycan layer on the surface of the bladder. That's the mucus, right? So Elmeron is believed to attach to mucus. Well, one of the theories that we didn't really understand is that, well, the retina has mucus on it too. The retina has GAG layer too. So their guess, because they're still trying to study this, we don't have absolutes here, is that somehow the medication is making it to the GAG layer on the retina, and it's changing the color. That's why it's called pigmentary, changing color, pigmentary maculopathy, and it's progressive. The more exposure, the more things change. So these are the same patient over time. So you can see in these 3 pictures, modest changes, little changes, little changes. And then look at this. This is a period of time later. Now we can see real visible changes on the retina. And now late stage, we see a lot of changes on the retina, right? Just a lot. So that is what is happening in patients who are getting pigmentary maculopathy from Elmeron use. Now, here's another picture so that you can see this. Right? Really clear. And there's even a, let's see. And then this is a three-dimensional picture of the retina from the, you know, basically from the, well, I don't know how they take it. Obviously, I'm not an eye doctor. But you can see changes. You can see changes in the surface of the eye right here, right? Look at that. One of the things that they really dreaded, and the doctors wrote it in their first letter to the editor that began this whole journey, is that they were worried that it could be progressive over time, even after you stop the medication, because there's one other medication that does that. And so that was their great, great worry, was that you could stop the med and a couple of years later, you start seeing this damage to the eye. And it was a ophthalmologist at Harvard who basically proved that that was happening. So she had a IC patient come in with severe eye abnormalities on one side. They go through everything. There's no genetics. There's no other retinal disease. They couldn't figure it out, and they diagnosed it as basically kind of like a unknown chemical exposure that had damaged her retina. Okay, and so there was a mystery. So much so that the doctor remembered this patient. The patient comes back several years later, and now it's in her other eye. And again, they do the exact same workup. They can't find any causation for it. Their assumption, again, is that it's an unknown chemical irritant. And then the Elmeron story came out, and the doctor remembered this case, went back into her record, and this patient, too, was taking Elmeron and had taken it for a long time. But here's what made her case so unique, and that is that after the first year, she stopped using it. But 5, 6, 7 years later, the damage was progressing. So that's why that there are lawsuits, and the Emory Eye doctors did their due diligence. They found the first clinical trial done to help support the FDA approval of Elmeron, and in that very first study, they noted changes in the eye, including retinal hemorrhages. So the real legal question is, okay, you found this in your first study, did you monitor it? And that is for a jury and a judge to decide. Tia, getting back to your question here, any supplement recommendations for a 30-year-old female who believes that her pain is caused by low estrogen? The very, very first thing that would normally be done is you would get your urine tested by a doctor and talk to your doctor about this. Because, listen, when you're 30 years old, if you're in a relationship and if you're having sex, there's a very good chance that, infections happen. So the way that I would be working through this in my brain, if I were 30 years, well, I was 32 when it started, is I went to the doctor. They tested me for every sexually transmitted disease known to man, even though I was not in a relationship at the time. And I said, I'm not in a relationship at the time. And ultimately, in the end, all that testing came back negative. And you're going, but what the hell? Okay. That's when I think it's important to take a step back for a moment and say, okay, now they've ruled out UTI. What's the next thing that is easy to think about and to consider? And that is diet. Is there a chance? Because a bladder, like any other part of the body, can be injured. And generally, it's injured through some sort of chemical exposure. So are you drinking way too much coffee, energy drinks, diet soda, cranberry juice, green tea, black teas, taking a lot of vitamins, a lot of vitamin C? Chemical irritation of the bladder happens. And for a lot of you, you have no idea that you're just thinking you have infection or bladder disease when it really is that ridiculous cup of coffee you're having in the morning. So that's why we want to rule that out by losing those irritating foods for like 3 months. You can't just lose it for a week. You got to lose it for like 3 months and just see what's happening. Hi, Sue. I would also want to know, have you had COVID? Because if you've had COVID, it could be COVID cystitis. I was working with a man this week, last week, who I told this on Friday. You know, he goes, "Is this the ICU network?" I'm like, "Yeah." "Can you help me?" And I'm like, "Well, I'd like to try." He goes, "I'd like to talk about my prostate." And I'm like, "Okay." And so he's like, "What do you know about a prostate?" So I give him my little spiel on the prostate and prostatitis. And I said, "Well," and it's like, "You got an appointment with your doctor?" "Yeah, in 2 months." I was like, "Okay, that's good, because we need to make sure you don't have prostate cancer. They got to do the proper diagnostic workup." So I'm really glad you made that appointment. But now I want to talk to you about something else. Did you know that a lot of these symptoms can be caused by your diet? He's like, "What?" And it turns out he's drinking energy drinks, he's drinking green tea, he's not drinking water, and cranberry juice. That's all he's drinking. Energy drinks, cranberry juice, and green tea. And I'm like going, oh, I was pacing out in front. I'm usually walking up and down the street when I'm doing coaching. And it's just like, dude. Anyway, let's just say I blew his mind and said, "Okay, so listen, while you're waiting to go to the doctor, would you just like back off on those foods for a while? Let's see if we can get, maybe all this is you just exceeded your capacity of your bladder because your diet's so, acidic." And I think he's going to be a new man. I do. I think he's going to feel a lot better. But I'm glad he's going to the doctor, because I can't give you medical advice. My job is to educate you, inform you, kick you in the butt, and get you back to the doctor with a new set of questions. Sue says, "You look good in blue." Thank you. Is anybody else like this? Literally, when I get up in the morning, my brain just says, "This is what you wear today." Like, I literally got up, walking through the house, thinking about it, and the image of my blue hoodie, but this is a different type of hoodie, and my white tank top. My brain told me, and I tried to put other things on. It didn't fly. I had other things on that looked good. It's like, nope, my brain told me you got to wear the blue. I'm wearing the blue. This is from the Venus Williams tennis collection. Because in the end, I'm a tennis player, even though I can't play anymore. In fact, I just got my racket out, and I was bouncing balls on my racket. I was a professional tennis player in my 20s. So, but now my body's so hurt from that I can't. I want to so bad. I'm going to go down to the club, hire the pro, and just hit balls with them. I miss it. Tia says, "I went through a 4-month diet restriction, but didn't seem to make any difference. I noticed my symptoms coincided with my period. I've never been a coffee drinker, and I've given up all caffeine." Well, so Tia, and you guys on YouTube, I apologize. You're on slow mode. You can only post one message every 60 seconds because spammers come in, and that's how we stop the crazy people from coming in and taking over the YouTube channel. I guess the right question to ask you is, what makes it worse? What triggers your symptoms? Does food trigger your symptoms? Does sex trigger your symptoms? Does sitting trigger your symptoms? What triggers your symptoms? Sue says, "Acetone nail polish remover put you in a flare for 2 weeks." I used it last night because I tried to get all. Fingers are pointless when you're on a computer all day, but this is the best I can do for my fingers with my one ring. But chemical sensitivity is real, my friends. Chemical sensitivity is real. Amy says, I had a urodynamics and cystoscopy done this week. No Hunners. Yeah, baby. Bladder only held 250 until I couldn't handle anymore. Okay, so that was your waking bladder capacity. No answers yet, but scheduled for an abdominal MRI first week of February. I'm able to go 3 days until I need lidocaine, bupivacaine, heparin, and still at bedtime. It's slowly improving. You're going to start pelvic floor physical therapy. Good. So Amy, you have fundamentally very good news here. You do not have Hunner's lesions. So let us celebrate that. Let us celebrate that. But here's what we do know, and that is that the nerves in your bladder are sensitive. How do we know that? Because when they did the urodynamics, you could only hold 250 cc's. For those of you who don't know what a urodynamics test is, you're awake, you're laying on a table, they just slowly fill your bladder with fluid, and then they ask, tell us when you first feel the need to urinate. Tell us when you first feel pain. And all they're doing is testing your nerve function. And so your waking bladder capacity is a bit low. Not terrible. I think mine was about that too. Mine might have been 275, something like that. So now we have to figure out why. Is it because you have central sensitization? I mean, if you've got very sensitive skin, a wicked sense of smell, any other painful conditions, and we're going to focus on your central nervous system. Or is it confined to your bladder wall, which would put you in that different category in Dr. Nichols' system, which would be primary storage symptom syndrome, where it might be interesting to try mirabegron as a therapy. And fundamentally, are your nerves dysfunctional because you have tight muscles? So I'm really, really glad that you're going to go to physical therapy, because that's a really, really important piece of your puzzle. Sue says, strong chemicals, fertilizer, acetone, food, strong candles, room fresheners, stress, and sitting too long. Yeah, I literally go crazy with strong smells. Like I get very upset. It like turns on this something in my brain. And I literally have to run out. We only have one room with carpet. That's my parents' bedroom. Thank God, since they fall, that's important. And I hired a carpet cleaner, and I said, you may not use any chemicals, nothing, just steam, nothing else. And I said, listen, I smell everything. It gives me bad headaches. I cannot have you use anything. And it's from Coit. And he's like, not a problem. So I'm sitting in here. He's starting there. I start smelling oranges. And I jump up, go tearing in there, open the door. Holy moly. Dude, what did you do? I told you can use nothing. And he goes, oh, my corporate just gave me this to try it. It's like, dude. And by this time I have asthma and I'm gasping for breath and I'm running out of the house and I am just, oh. And I reamed his butt and I reamed the company and I got my money back and I was furious. How many times do I have to say? Same thing happened with buying new couches from Lazy Boy. Do not ever, seriously, if you're chemically sensitive, do not even get me started on Lazy Boy. I would just end this with, I had to plastic off my living room after they promised no chemicals. I called the CEO back east and went CEO to CEO. Because, listen, man, be bold. You need to fix this. Get this furniture out of my house right now. How dare you guys do this? And they did. The next day, they took it all and I got my money back. And I had no couch for a while. Tia says, always have pain while your bladder is filling in after peeing. Pain intensified most during ovulation and started my period. Okay. I mean, you're 30 years old, Tia. So we had a case study published of an 18-year-old who developed severe IC symptoms suddenly and got progressively worse over a year. She was diagnosed with IC, with UTI, with yeast, you name it, they diagnosed it with her. In the end, it was her birth control. She had just started birth control, and the birth control basically turned off all of her estrogen, and she went into menopause, and her skin was massively compromised. So once she stopped the birth control, it took about 6 weeks, but all of her symptoms went away. So have you started new birth control? I mean, Tia, your story is exactly like mine. I was exactly that way too. When my symptoms started, I had pain with filling. I didn't have pain so much after urination, but I had a massive amount of pain before urination. And my pain intensified absolutely the day that I ovulated and the start of my period. But in the end, at least, and they gave me estrogen cream back then, but my skin was healthy and I was not on birth control. In the end, for me, the foundation of it was pelvic floor. My bladder wall was healthy. My nerves were not healthy. And the reason they were not healthy is because my muscles were tight and I had central sensitization. So once we worked on restoring the health of the muscles, that's when all of my bladder stuff got massively better. Amy says, I believe this flare was triggered by stress and not sleep, just caused by more stress and type 1 nerve. Yeah. Amy, didn't we talk last week? Laura said, is there anything for IC that affects the gag layer and bladder that could also impact the retina similar to IC? Not that we know of, because there are no other treatments out there like Elmeron that have been developed. The only, and again, the Curtis Nickel guidelines kind of reinforces this concept of gag layer. In fact, here, hold on a sec. Where is it? Oh, you know what? It's not printed out. It's on this computer. Hold on. Well, he talks about gag layer mimickers. So a gag layer mimicker is chondroitin or hyaluronate. You heard of glucosamine chondroitin for arthritis? Why? Because these are molecules that are naturally found in the human body. Just like sodium hyaluronate or hyaluronic acid is a lubricant found in joints. Well, all of those are found in the bladder wall. Oh, Amy, awesome. Oh yeah, I remember. Sorry. So we look for ingredients that are naturally found in the bladder wall. So it's going to be chondroitin or hyaluronate or heparin. I don't think that heparin is actually found in the bladder wall, but it is. I might be wrong. I'm zoning on that right now. But anyway, chondroitin, hyaluronate, heparin. Those are the key gag layer mimickers used in a bladder installation. And what the research showed with that a couple of years ago, they found the most important ingredient was chondroitin, because chondroitin was essential to the superficial integrity of the bladder wall. So that we apply that same thing to supplements. You know, the challenge with Elmeron and the challenge with supplements is you have digestion. And digestion is going to break up and destroy a lot of it. So very little of it's going to actually get to the bladder to be helpful, but there's always a chance that some of it will. But pentosan polysulfate is synthetic. Chondroitin is natural. Sue says, what do you think would be causing my body to shake sitting on my TENS unit lead? It's making your leg shake so bad. It only happens when I cross my right leg. The lead is now on my left. Well, you're tweaking the nerve, hun. If your leg is shaking that violently, then you need to turn that. You need to call your doctor and you let them know about that. And I would be turning that sucker off, because that's not normal, healthy behavior for muscles or nerves, right? Charlie says, and you guys, we're simulcasting on Facebook and YouTube. So if I'm looking over at this computer, I'm looking at YouTube. If I'm looking here, I'm looking at Facebook. Charlie says, what are the things that worked on your muscles to get the relief you described? Pelvic floor physical therapy. I did it again the other day. Pelvic floor physical therapy, working the length of the muscle. Let me get my model here. You know, and I'm getting old, and so when I get up, man, my piriformis right here, woo, that's tight. Ah, that is some tight muscle. Tender to touch, tight. Ugh. Yikes. Here, hold on a sec. I just want to. What's the score? Dang it. Okay. Come on, I'm a 49ers fan. I gotta pay attention to that. Okay, let's look at the pelvic floor for a moment. Let me take out your guts. I am now taking out the guts. The guts are gone. Oh gosh. Hold on. You know it's not a support group meeting with me if something doesn't fall. Okay. Okay, let us just take a wee look at the human body here for a moment. Your bones for a moment. Here's your pelvis. Remember, now the way the human body is designed is the bigger the bone, the more weight it's meant to carry. Therefore, the biggest bones in your human body are your hip bones, because they carry the weight of your torso. Here's your pubic bone. You notice that there's actually two bones that are connected, right? If we go to the back, we have vertebrae from your spinal cord. We have your sacrum. These holes in your sacrum carry nerves, your pudendal nerve, that come out and do all sorts of things. And then, of course, we have the oh so mighty tailbone right here. And I want you to notice everything that attaches to the tailbone. This is the center. Am I holding a cricket? Oh, I'm holding a cricket, right? So this right here is the center. See, your pelvis mirrors each other. You've got the left side and you've got the right side, right? Let us look now at muscles, shall we? Muscles. So you've got two different types of muscles in your pelvis. You've got your smooth muscle of your bladder versus the skeletal muscle of your pelvic floor. These are skeletal muscles right here, the ones on the inside of your hip bones. These are the muscles that help you open and close your legs. They're the ones that help you move. They are movement driven, right? The challenge with these muscles is you can't easily get to them. The best way to get to them is through a hole. Through a hole. Hello, vagina or rectum. So look at what happens when I stick my finger through the hole. Oh, I can reach the muscle. See that? And this is what a physical therapist will do. They will use their finger and they basically just follow the length of the muscle. You see that? We're following the length of the muscle, both sides. See that? Both sides. And you can see we've got muscles here. What happens with the muscle when it gets tight is it lifts. It lifts off the bone. And as it lifts off the bone, it starts interfering with blood vessels and nerves and stuff like that. And the best way to get the muscles back into position is to just go the length of the muscle. We're just teaching the muscles, just like calm down, muscle, calm down. You can relax. We want you to go back where you belong, muscle, right? Now, our challenge here is you got deep muscles and shallow muscles. For the shallow muscles, they don't have to go deep. These are your shallow muscles, right? So we've got the rectum, the vagina, the urethra. Obviously, men do not have a vagina. And this area is really important. This is the perineum, And the perineum is a hot spot. At least for me, I had the worst pain was always right in this area. And I never understood why, but now I know why, because immediately above the perineum is something called the perineal body, which 4 muscles attached to. So if you have pain right here, it's because of the muscle above it that's probably driving the pain. So if you're having pain more in this area, then your finger doesn't have to go in that far, and you might be able to do it at home. But you need a physical therapist to kind of teach you what to do, right? When I first started using my wand, I didn't know what to do. For about a year, I didn't know what to do. I was just like, I don't get it. Now I totally understand what to do. But that was working with a physical therapist and reading some books. Chris, let's see. Chris says, I was diagnosed with IC in 2001 after a bladder biopsy, treated for a few years, went into remission, just started having horrible symptoms in the last 3 weeks. Is a urologist the next best step? Chris, are you a guy or a girl? I can't tell from your picture. So normally when your symptoms get really severe suddenly, we want to rule out UTI. We want to rule out superficial irritation from having a very, very bad diet. We want to rule out trauma. Did any sort of fall happen 3 weeks ago? What happened 3 weeks ago, a month ago, aside from Christmas? Was there anything that happened that you associate with the onset of your symptoms? Tia says, I was put on birth control to help, and over time it has helped. I don't like the other symptoms it causes, so I'm looking for alternatives. I understand. Alexa says, how does chondroitin help the urethra? Well, the urethra has a layer of gag on it too. Your urethra, your bladder, your vulva, your vagina, and your mouth are all mucous membrane covered organs or structures. That layer of mucus is essential to their health. That layer of mucus is a barrier. It protects tissue. It makes it difficult to infect. That we call it the mighty mucus. So when that mucus is compromised by estrogen atrophy, or if the mucus has been stripped away by some sort of chemical exposure, then urine is going to reach directly into that area and trigger it. And so chondroitin might provide a bit of a coating effect. Should you take bladder rest on an empty stomach? No. Take it with food. All the supplements really are meant to be taken with food. Chris is a girl, no trauma, just woke up with pain. Chris, had you had sex? And tell us about your symptoms. If you have pain, where is the pain? Is it on the outside on your skin, or is it internal? And if it's internal, is it in your urethra or is it in your bladder? You guys, this is my breakfast and lunch, so I apologize for drinking, but I got to. Urgency, pain in the bladder and urethra, no pain when actually urinating, though. Did you have, over the holidays, like on New Year's, did you have alcohol? Oftentimes what we see, Chris, is that you have been stable for years, but then there's something that happens which triggers more bladder irritation. And the question is why? And often it's just aging. So if your symptoms began in your 30s and then you're really controlled, and all of a sudden in your 50s, bam, here they are and they're bad. Why? Well, the loss of estrogen changes the superficial integrity of your bladder wall. And so that cup of coffee or whatever you were enjoying in your 30s and 40s all of a sudden hurts you in your 50s. And so 9 times out of 10, when symptoms get worse 20 years later, it's usually because of a change in your skin health. You know, I am having pain right here. You're 44. Is high dose aloe recommended? Well, aloe can be soothing to a sunburn. So you might find aloe soothing, but it does not have what I call a constructive effect, because the bladder is not made of aloe. There's no plant material in the structure of the bladder wall. So we look for things that would have more of a constructive effect on the bladder wall, and that would be chondroitin. So I would be looking at my primary goal would be chondroitin. And then, you know, using a little bit of aloe to just try to calm and soothe the area makes sense. The aloe that we have now is called Aloe Path. Where is it? Is it up here? Where's my aloe? There it is. It got lost. So, Aloe Path is a combination of organic anthracnone-free aloe with PEA for pain relief. And so as we were looking for kind of our next generation aloe supplement, I decided that I wanted to increase the odds that aloe might have more of a soothing effect by combining aloe with PEA, which is palmitoyl-ethanolamide. PEA was found to be remarkably successful at reducing IC pain in 2019 in a big study from Europe. And so this is the aloe now that we have in our shop, Aloe Path. And it's low dose, it's not high dose. You know, and the reason why is because, you know, when we think about our subtyping and we think about the reality of the many different types of physiologies for IC, there is a huge group of us who are sensitive, and I'm one of those. And for us, we don't like taking anything. I do not like taking anything new, because I'm like the queen of side effects. Redhead, central sensitization, it is what it is. And when I was getting my pharmacology degree, they taught a concept called lowest effective dose. What's the least amount of medication you can take and still get a beneficial effect? And versus what's the most amount of medication you can take and get a beneficial effect without hurting yourself, right? Least versus most. For me, I always looked for the lowest dose. So as an example, when Cystro Prote came out 20 years ago, I tried it. I started with 1 capsule. And again, this was before I knew I was pelvic floor driven. But anyway, did 1 capsule with food, I was fine. Did 1 capsule for several days, I was fine. Went up to 2 capsules, diarrhea. So my body could tolerate one, it could not tolerate two. And so as you are looking at therapies from medications that your doctor suggests to you, and so for those of us who are sensitive, we almost always start with pediatric doses, half doses. I mean, that's very, very common. Some of you some of you are really good with high doses. I'm not. I'm a low dose girl. So anyway, so whether it is a therapy or whether it is a supplement, it's all about finding the dosage that works for you. And for me, it's all. I can take 2 Peora and I'm fine. I've never had an issue with Peora. I can take our low acid multivitamin Bladder Smart. No, I had a problem with that. I know I can only take 1 Cysto Protec at a time. And now I don't do any bladder therapies because I know my bladder's healthy. I don't need to do something for my bladder. It's healthy. What's not healthy for me are my muscles and nerves. And so I put my money on pelvic floor physical therapy and on things that will calm my nerves down, like Peora. But we're all different. So what works for me may not work for you and vice versa. It's about finding what works for you. Amy says she's been on Prolia for years, gets a shot every 6 months, and it's never bothered her. Good. Life, right? So that's for osteoporosis. Yeah. So Laura is just asking that question, and Amy responded to that question about Prolia. She's doing fine with it. I've never taken it, so I don't have any context to give you myself from personal experience. Oh no. 28-7 Eagles. No. Darn it. Oh man. Darn it, darn it, darn it. Oh well. Wynn says, trying my TENS on the ankle stim squats and it's helping. Good. Just remember Wynn. So Wynn's talking about urgent PC, also known as post-tibial nerve stimulation. That's something that I did early on. Whenever you're using a TENS unit, it should never hurt. It should never hurt. More is not better. If you have a TENS unit on and it's hurting you, you are damaging nerves. So if you're doing urgent PC or post-tibial or just using a TENS pad, turn it down if it's hurting. We don't want to damage nerves, right? Sam says, I had a flare after my colonoscopy. Is that typical? Do you have any knowledge around that? Well, Sam, there are three things that would potentially trigger that. Number one, if the colon prep had a lot of acid in it, a citric acid in it for flavoring from like Golightly, that could have irritated it, although it's rare, but it can happen. You also have to remember, too, that as you're sitting on the pot, emptying your bowels for hours and hours and hours, your pelvic floor goes into spasm. So you could be having a pelvic floor flare from that. And number three, just stress. Stress is real. Nobody likes having a colonoscopy. It's stressful. It's annoying. They've got some new stuff now. You can swallow a camera. My mom did that. That was kind of cool. Sam says, yeah, that makes sense. Thank you. Yeah, I use it. Honey, when did you have it? Did you have it on Friday? If you I would be upping your water intake. I would be, just not a lot, just a little bit. Let's just try to flush as much out as you can. And I would be using a mega heating pad. We just got a big shipment of new heating pads in, guys. I have a lady here in Sonoma who makes them. These are handmade here in California. Hold on a sec. Let me get one. So this is our body heating pad. No, this isn't the body heat. This is the Comfort Valley ginger bee. So these are handmade here in California by Donna. I just saw her over the weekend. She's a retired teacher. She makes these for us. And let me just, this is a brand new one. So we just got 30 of these. So here's what's so cool about this. Look at the shape. It is perfect. It is perfect, right? It is absolutely perfect for bladder pain and pelvic pain. Ironically, it's actually a neck pad. I use it on my neck too. For my neck and upper back, see that? So I have one of these asleep with me every day. It's great for neck pain, and it's great for pelvic pain, and it's in the ICN shop. It's heavy. 2.5 minutes in my microwave. That's what it takes to get this warm. It'll last for about 30 minutes. And it's heavy, guys, and it weighs a lot. It weighs over 2 pounds. So the shipping is like, $20 or $18. But it'll last forever. I mean, unless you get it wet or unless you burn it, it'll last a long time. I mean, I've got 4 of these that I use personally. And they're all over the house, right? And the only one, and some of them I've had for over 15 years. I've only lost 2. One got ripped in my recliner. It went in the recliner and it got tangled in the mechanics and it just burst open. And the other one, I had on the stove, and somebody turned the burner on and burned it. All the others are still alive and kicking and working well. Carrie said, the low acid bladder smart vitamin set your bladder off with urgency frequency within 2 hours and needs to. Okay, girl, listen, that I'm surprised, but you're not the only one. There are some patients who cannot take any multis. You cannot take any multis at all. And I respect that. It happens. I'm going to say 5%, maybe 5% of the people who try a low acid vitamin can't do it. And I'm sorry that was you, but it happens. So what I would do instead, if I were you, is I would start with individual ingredients. B12, vitamin D. So B12 and vitamin D, what the diet studies have shown, as well as 30 years of kind of patient reports and experience, is it's the vitamin C and the B6 that seem to be the most irritating. So I would try to build your own vitamin with other things that are important. And you're having a gastric sleeve and you need to find one. I'm okay with vitamin D. Well, there's only 2 others on the market. I mean, there's Multi-Right from Far Labs, and then Desert Harvest has a low acid vitamin. You could try theirs too, but ours is like the mildest one. So if you reacted to ours, I think you'd react to all of them. You're just going to have to try it and see how you do. The other thing you could potentially do, which would be an interesting experiment, would be maybe to take a pre-leaf with the vitamin. That would be interesting because the pre-leaf would then balance any of the residual acids Carrie said, thank you. Yeah, that's what I thought. That would be reasonable. That would be reasonable to try because the gastric sleeve is going to be tricky, you know. It's gonna. I understand you're definitely going to need that help nutritionally. You know, I'm going through this personal change right now, getting older, and I'm in two ways with my food and with my internet. So with my food, I'm getting really simple now. Like I do not need a fancy meal. I do not want to go to a French restaurant. I don't need to do any of that. I don't want to do any of that. I like simple, fresh food. And there's this great TikToker, even though I don't watch TikTok anymore or hardly watch it anymore. It was a parent feeding their toddler. And they basically just gave him a handful of tomatoes and a handful of chopped avocado and a handful of this, little maybe some shredded chicken, this. And it was like food at its purest. And it was so cool to watch this little baby actually wanted to eat tomatoes instead of something sweeter because they were allowing that child to just enjoy the flavor. And that's like, I mean, especially once my parents are gone, since I'm cooking for them and they have to have a lot of creamy stuff and stuff like that. I just want really simple food. You know, like my breakfasts are usually Ezekiel bread with avocado or almond oil or a scrambled egg on it. That's it. I don't need anything else. And I don't like fancy sauces or rubs or things like that. I just don't like that stuff. Food, you know, because I had IBS in my 20s and it was very severe IBS, food was never my friend. Food is not something that I enjoy like other people enjoy. It's just like I look at food as, will it hurt me or help me? You know? And even though I don't have IBS now, one of the reasons why I don't have IBS now is because I'm very careful about what I eat, right? And I don't eat those trigger foods. And I don't eat leafy greens at all. And I'm so much better for it. I'm so much better for it. It's so nice to not have, you know, IBS every day anymore. And then the other thing that like I was thinking this morning. It's just like I hate social media right now. I just hate it because it's just people just trying to poke each other. It's just poking. It just people are just trying to get a rise out of people, and I'm sick of it. I'm just sick of it. I just want to have nice, normal conversations with people. I don't need somebody I don't know throwing something nasty at me to try to get me to react to something. I just think it's damaging society. It's damaging all of us so badly. It just, I don't know. That's just my thought. Sam says, I got off all social media too. I'd rather just keep in touch with my friends one-on-one. Yeah. It just feels very harmful. I mean, it's been, and you know, I should talk because I built the very first website on IC, but I stand by my website. It's not a provocateur. We don't post things to get people upset. I try never to do that. But that's like 1% of social media right now. And Facebook, my friends, seriously, I love you, but Facebook is a pit. And Instagram, it's just dog eat dog. It's awful. And now they're going to let you know who back on Facebook, and it's like, great, the master. Whatever happened to just talking with your neighbors and doing something for your community and being nice? Sam says, say it, truth. Yeah. And I think what I don't like is what it does to my mind. So TikTok is evil. I mean, you have to understand that there are companies in Silicon Valley dedicated to creating technology that will trigger your addiction centers. Their goal is to get you on their app and leave you there because you make them money. They don't care about your health. None of them care about your health. They just want your eyeballs so they can give you an ad so somebody will pay them. So the longer they keep you engaged, the more money they make. But the question is, how are they doing that? Well, they're triggering addiction centers, my friends. They're triggering the same centers of your brain that heroin triggers. And I know, so that's what, so like, I notice a very distinct change in my habits because of TikTok. Because I could spend hours and hours reading. You give me a good fantasy book, whatever, action adventure, Jack Reacher book. There was or my favorite Black Dagger Brotherhood series. In the old days, you give me that book and a cup of something hot to drink, I will sit on my couch for 3 hours and drink it and read it. That's pure joy for me. But something happened with TikTok because now when I try to do that, I last about 20 minutes and then my brain goes, I want to watch something. And I catch myself closing my book, going to my app, opening it, and going, wait, that's my brain rewired. And now I'm trying to retrain my brain to stop doing that. Now, watching videos, long videos, educational videos like this is fine, but it's those videos that they're just giving you endorphins over and over and over and over and over and over and over again. And it's like electronically pickling our brain in a weird way. I don't know if that's the right way to say it, but it's pissing me off. So I believe that TikTok should be banned. And I believe that YouTube should get rid of short videos because now I turn to those. I am trying not to touch my iPad during the day at all. And it's hard. I set it up for my mom so that she can watch airplane videos, the LAX live videos. But when I pick it up, it's hard to put it down. And that's new for me. And that really is just since TikTok 2 years ago. And I have deleted TikTok 4 or 5. It is deleted now. It is not on my iPad, but I hate my iPad now. It's like, but I have to have it to test stuff, but I hate it. I don't want to touch it. I don't want it in my life anymore. Laura says, but my 87-year-old mom can go back and forth between short videos and books. I don't get it. Well, I can too. But the thing is, I'm not focusing well on the book anymore. I mean, I read medical journals every day. I can read and I have no problem. I have no problem with the content at all. It's just that it's like my brain is craving a video. There's like this weird crave thing going on. And it's like, stop it. I don't want to watch those videos anymore. So I truly believe that TikTok is harmful. I do. There's just something about it. Laura says, I'm like you. I find tough reading at length now. Yeah. I mean, I didn't even finish reading the latest Diana Gabaldon Outlander book. Those were my jam. I didn't even finish reading it. I can't eat, but I also can't watch the series because I don't like it. But the Diana Gabaldon Outlander series is phenomenal. The Harry Potter books, phenomenal, especially on Audible. My favorite series now, though, is the Black Dagger Brotherhood, which is a vampire series. You know, when you do the work that I do, where you're working with so many people who are really struggling, at the end of the day, you have to disconnect. Like I have to disconnect for my sanity and just do something completely different to give my brain something. And you have to have good self-defenses when, you know, when you're an empath, it's really easy to bring everybody else's emotions into your heart. And we all do that. And I really do that. But I have to kind of push them out at the end of the day so that I'm not crying all night. And so what I do is I play computer games, World of Warcraft. I'm a hunter elf, raid leader, guild master. Well, not so much anymore because I don't have time. I used to do that every day. I do that maybe once every 2 weeks now. Fortnite. I love playing Fortnite. And there's a lot of us who are my age. I wish they had a tournament division for over 60s because I would conquer. I would conquer that. And I really like vampire and shifter books. Jennifer. Anyway, you know, I do. I just got to be very different. Fantasy books, Anne McCaffrey, Dragon Riders of Byrne, my favorite books of all time. And in World of Warcraft, I play with a senior member of the Department of Defense. A lot of military guys and women. When I can, I just don't have time right now. Like I can't do the stuff I would normally do right now. I haven't been able to for about 8 or 9 years. Elder care. But we all got to find our ways. But, you know, like the walking is the beast. Now that, oh my God, it's 31 to 7. Oh, dear Lord. Somebody said, man, that last play really makes me feel for 49er fans. They're doing everything they can to survive this. Oh. Well, it was a good season. They did their best. Darn. Darn, darn, darn. We need some poo-poos. Do you guys know what poo-poos are? What about for dinner? So like the other thing, like, again, as I'm planning for life after elder care, you know, what do I want to eat when I'm on my own? And it's like, you know, I'm like perfectly fine with refried beans, guacamole, and tortilla chips for dinner. Give me some shredded chicken on top, a little bit of fat-free sour cream. I'm good. I don't need anything fancy. Just super easy. Grilled cheese sandwich. Give me a grilled cheese sandwich with a little avocado on it. I'm good. Plain popcorn, no salt. I'm good. All right, you guys. Well, listen. Y'all are being very quiet now. So it is almost 3 o'clock. You're making it easy on me. Oh, hey, you know what? You know what? Okay. So we talked the other couple weeks ago about how I'm going to start reading chapters in my book. Oh, wait a second. IC 101, not just a bladder disease. This is my latest book. Going to be rewriting this again. the spring with all the new stuff. But it's still really good. Carrie says, do I do private consulting? Yes, I do wellness coaching. And I'm happy to talk with you. If you just have a couple questions, you can just call the IC Network. The phone number is right there, 800-928-7496. I answer the corporate line, the vendor line, and I do the patient education phone line. I do not normally answer the sales phone line. So if you just have a couple of questions, happy to talk, no charge, nothing at all like that. But if you want to spend some time going over your case, if you could sign up for a coaching session, that would be great, because we do have bills to pay. And it does help to have some income coming in. I'm a terrible businesswoman since I give almost everything away for free, but it is what it is. All right, hold on a sec. Give me a momento. There it is. Hold on, I'm just trying to grab a file here. You see that score? Is your GERD bothering you? It's my dad. What? No, I don't want to open Microsoft Word. No, you do not want to open Microsoft Word. Word crashes all my computers. For God's sake, force quit now. No. So I said a couple weeks ago that I would try to read a chapter in our meetings, and then I'm going to put them all together as a video series where I'll just take those sections. And so since you've gotten a little quiet on me right now, I think I will go ahead and read another chapter. So let me just do this. Okay. Let us do the introduction, and then maybe we'll do chapter 1. Okay, introduction. So this is IC 101. It's not just a bladder disease. We released a couple years ago, written by Gay Sandler, Andrew Sandler, and myself, Jill Osborne. Our foreword we read last time by Robert Eckenberg. So here's the introduction, then I wrote the introduction. The dream of every patient diagnosed with IC BPS is to find a cure. We want a treatment that will eliminate our bladder symptoms and pain, allow us to eat foods or drinks that we've avoided for years, work comfortably, and of course, enjoy intimacy again. If you've had IC for more than a year, the odds are that you've tried a variety of treatments such as oral medications, bladder installations, OTC supplements, neuromodulation, and perhaps even Botox or cyclosporin. Yet despite this wide variety of interventions, many of you are still struggling to find relief. As much as we would like to have one treatment that would heal most patients, it simply isn't available, and there's an important reason why. Visit any IC support group or online support forum, and you'll quickly see that not all patients are the same. Some have agonizing Hunner's lesions on their bladder wall, while others have a normal, healthy bladder, myself included. Some patients struggle with mild frequency and urgency, while others have intense pain. Some also struggle with other chronic pain conditions such as IBS, vulvodynia, fibromyalgia, migraines, or TMJ, while others only have bladder symptoms. Despite their common diagnosis of interstitial cystitis or bladder pain syndrome, clearly these patients are not the same. You can see even more diversity in the events which appear to trigger the onset of IC symptoms. Many women report that their symptoms began after delivering a baby, while men often report that their symptoms began after riding motorcycles or bicycles. A history of athletics and or pelvic traumas, repetitive falls, or tailbone injuries are common in both sexes. There is a cluster of men and women whose symptoms appear to begin after an infection, whether it be a simple UTI, an STD, or even Lyme disease. Exposure to harsh chemicals, chemotherapy, ketamine, excessive consumption of coffee or soda is a common cause of bladder irritation. Aging, hormones, and genetics can also play a role. So, given the myriad of ways that IC manifests in different patients, as well as the diversity of events that appear to trigger its onset, it's no surprise that a one treatment fits all approach, much less a one cure fits all approach, does not work. But there is hope. IC phenotyping, also known as subtypes. Amy, I agree. Recent advances in the phenotyping of IC-BPS have revolutionized the care of patients around the world. Patients in Europe are given the most aggressive diagnostic workup requiring hydrodistension. Based upon their symptoms and biopsy results, they are then classified into one of 12 different subtypes. The Canadian Urology Association encourages the use of a 6-point system known as U-point or input. And the American Urology Association has not yet recommended a specific system, though several are being studied. Although that's not true now because our new guidelines, see, I've just ruined my narration. Okay, I'll have to cut this part out. Our new guidelines that were just released do differentiate into 3 groups for AUA. Okay, break. I use a system developed by Dr. Christopher Payne, former director of female urology at Stanford University in 2015. In his proposal, Dr. Payne complained that a diagnosis of IC often left both the patient and the clinician unsure of what treatments to pursue. He suggested if the diagnosis was more specific and individualized, a clearer and more effective treatment pathway would emerge. Dr. Payne proposed 5 fundamental subtypes: Hunner's lesions, bladder wall driven, pelvic floor driven, pudendal neuralgia, and central sensitization, each with their own treatment priorities. Within each category, some additional variants are recognized, such as genitourinary syndrome of menopause or chronic infection in subtype 2. And he also suggested that more variants could be identified in the future. The Payne phenotyping system encourages a more thorough diagnostic workup, more effective treatment, and provides better insight into the prevention and treatment of IC flares. It has played a significant role in my life and how I work with my clients at the Interstitial Cystitis Network. So understanding my type, central sensitization primary. Using Dr. Payne's system, my primary subtype is central sensitization. As a child, I have had very sensitive skin and could not tolerate bubble baths or wearing clothing that contained wool or had rough textures. My stomach began to rebel in elementary school. In junior high, my bladder became sensitive, and I often couldn't sit through an hour-long class without having to use the restroom. I began to develop vulvodynia in high school, which I had my gynecologist claiming that I had, quote, the most sensitive skin he'd ever worked with, end quote. Irritable bowel symptoms hit in my early 20s, along with some very new food sensitivities to oatmeal and chocolate. I began noticing more intense smells and tastes. Harsh chemicals, oven cleaners, turpentine, wood solvents, petroleum products had me running out of rooms or buildings. They hurt. I experienced sporadic migraines and TMJ. And at the age of 32, bladder symptoms hit so severely that I couldn't sleep or drive without severe pain and discomfort, and my anxiety levels were off of the charts. 3 key breakthroughs helped me make sense of my chaotic body. Researchers at the University of Maryland found that IC could run in families. That was interesting because my sister, mother, aunt, cousin, and grandmother each struggled with bladder symptoms and very sensitive skin. Then researchers started floating the concept of central sensitization in patients with bladder symptoms who had what appeared to be normal, healthy bladder walls. They believed that the nervous system was the root of their bladder symptoms. One of the classic signs of central sensitization is a very sensitive sense of smell and sensitive skin. I came to realize that almost every medical condition that I've struggled with could be attributed to a sensitive nervous system and, more importantly, my genetics. It was never my fault. We also understand what is driving some of this sensitivity. Small fiber polyneuropathy is found in over 60% of patients with chronic overlapping pain conditions. The smallest in diameter nerves in the body have been injured. Neuropathies are associated with several illnesses such as diabetes, Lyme disease, shingles, and other viral conditions. Vitamin B12 deficiency is a well-known cause and fits nicely into one theory that some patients may have an inherited vitamin B12 deficiency disorder, also known as porphyria. And nerves can be damaged due to an excess of vitamin B6, heavy metal exposure, organophosphates, and sadly, some antibiotics that were often given years ago to patients with suspected UTI. But I have another complicating factor. I'm a redhead, and it is well known that redheads struggle with more pain sensitivity. I can personally attest to the fact that it takes more anesthesia to numb us for dental work. Red hair occurs when both patients carry a mutation of the MC1R gene, which also surprisingly affects pain processing in the brain. Redheads are more sensitive to certain kinds of pain. We often require more anesthesia for surgical procedures. And yes, we aren't being dramatic. Research studies have proven that our nervous system is different. I don't view central sensitization as a disease, but rather the landscape of my body. I am hardwired to be more sensitive, and it is my responsibility to calm and soothe my nervous system through diet, stress management, and various treatments as necessary. I respect the fact that my bladder, stomach, and bowel are easily irritated by certain foods. I choose not to drink caffeine because it overstimulates my nervous system. And I know that when I'm under stress, my body is more reactive. So I take the time to rest, relax, and practice good management skills, stress management skills. And I am remarkably healthier today than I was 25 years ago. My second and more painful subtype is pelvic floor driven. The year that my bladder symptoms began, I had broken my tailbone and developed a mild case of scoliosis. Because I was unable to sit through class, the teachers complained, and I was eventually seen by a urologist who diagnosed me with a urethral stricture, a narrowing of the urethra. And back in the 1970s, they forced the urethra open with a metal rod, and yes, it's as awful as it sounds. I had dozens of these dilations over the next few years, but in hindsight, I wonder why nobody asked, why is her urethra narrow? I believe my pelvic floor muscles, specifically the group of muscles known as the levator ani, were tight to compensate for my tailbone injury and or scoliosis. Hindsight has also helped me to see that what I thought were bladder flares in my 30s were usually pelvic floor muscle spasms. I was startled badly one day and felt like I was going to leak some urine. So for several hours, I deliberately clenched my pelvic floor muscles until I returned home. The result was a wicked, days-long flare of frequency urgency pain. This proved to me that muscles could trigger the symptoms that I had associated with my bladder for decades. And not surprisingly, pelvic floor physical therapy was far more successful at reducing my symptoms than years of bladder treatments. Patients who contact my office are often surprised when I say that we no longer consider IC an incurable bladder disease. Rather, we think of it as a pelvic pain syndrome. Why? Because other structures in the pelvis are often involved. Now we know why bladder therapies don't work. And for so many, and as Dr. Payne wrote, some patients are indeed curable if they are given the correct treatment, especially those with pelvic floor dysfunction. But we can't talk about effective treatments until we understand your anatomy. Are your muscles tight? Does your bladder wall have lesions? Are you suffering with any nerve-driven symptoms like sciatica, pins and needles, or PGAD? Does anyone else in your family share some of your symptoms? Do you have other painful conditions? The purpose of this book is to help you, the newly diagnosed and or veteran IC patient, understand more about your unique case of IC and to help you focus on the most effective self-help strategies. You can't find more qualified authors than Gay and Andrew Sandler. In their first two books, Patient to Patient, Managing IC and Related Conditions, published in 1998, and The Proactive Patient, published in 2014, they offered a veritable Bible of self-help strategies that have helped thousands of patients get through the day. They cover a diverse, important range of topics from managing diet and exploring treatments to the impact of hormones and aging on the bladder. A muscle and movement re-education practitioner, Gay shares exercises to relax the pelvic floor muscles. Andrew offers insight as the husband of an IC patient. And together they provide a toolkit to help couples maintain their intimacy and relationships. It has been a privilege to contribute to the second edition of this book and to introduce Dr. Payne's work. While there will undoubtedly be more phenotypes or subtypes proposed in the coming years, we finally have a system which makes sense of the chaos of life with IC. We can now more accurately diagnose patients and focus on more effective treatments. There is hope for patients with IC-BPS. You are not alone. You did not cause your IC. It is not your fault, nor are you damaged goods. Your IC could be the result of an injury or trauma to your pelvis rather than a disease process. And your job is to create an environment that will support healing of your bladder wall, your pelvic floor muscles, and your nervous system. Gay, Andrew, and I offer many tips that will help you through your journey with IC. And of course, if you would like to talk with someone or read more, please come visit our website, the IC Network. We welcome you. And Lori says here, holy moly, this part sounds exactly like me. You know, Lori, what's so cool here, because when this was all happening to me, I thought I was the only one. And I was profoundly depressed, upset, angry, you name it. In my 20s, I was just inconsolable because I hurt so badly in so many different areas. And it was such an important process for me to get context, because I really truly thought it was my fault. And now I know it was never my fault. And this whole progression of painful conditions is now completely understandable. We now know why it happens. And now we know how to treat it. And if you have multiple pain conditions like I did, then you do not have a bladder disease. You have multiple pain conditions. You have a neuromuscular disorder. And our therapeutic priority for me is to calm my nerves down, keep them calm and collected, and to calm my muscles down. It's that simple. All right. I'm going to read the next chapter too. See if I can get through it. Yeah, I can get through it. All right. Chapter 1. Subtyping IC-BPS, Beyond the Bladder. Spend any time in an IC bladder pain syndrome support group and you'll quickly learn that there is remarkable diversity in the IC patient population. For some patients, urinary frequency, urgency, and pain began in childhood, while for others it occurred after menopause. Chemotherapy or a very poor diet is a common trigger for patients at any age, but so is traumatic injury, such as fracturing the tailbone. Some patients struggle with chronic overlapping pain conditions, while others just have bladder symptoms. They've all been diagnosed with IC, but are they the same? No. Some patients suffer with such extreme urinary frequency that they cannot sleep at night, while others sleep for hours at a time without distress. Some struggle with intense pain, especially when they sit down, while others have no pain. Many patients experience a worsening of their symptoms after they drink coffee or cranberry juice, while others can eat or drink anything and not notice a change in their symptoms. Do they all have the same condition? Again, the answer is no. And the variations are the most obvious when looking inside the bladder. A relatively small percentage of patients have large bleeding lesions on their bladder wall, while others have a perfectly normal looking bladder. Yet both patients struggle with intense frequency, urgency, pressure, and or pain. Clearly, they do not have the same condition. IC has essentially become a grab bag diagnosis for patients with urinary symptoms for which an obvious cause has not been found. Today, we no longer think of IC as an incurable disease of the bladder, but rather as a chronic pelvic pain syndrome. Why? Because structures outside of the bladder, muscles, organs, and nerves can also trigger the urinary symptoms of frequency, urgency, pressure, and pain. Pelvic anatomy. From hip to hip, the pelvic cavity is a small confined area that performs critical functions for the human body. It carries the weight of the torso via the hip bones. It absorbs the stresses and pressures from walking, running, and jumping. It provides space for the bladder, the reproductive system, and the bowel. It has skeletal muscles that connect the torso to the hips and the hips to the legs. These muscles also hold pelvic structures in place. Nerves from the spinal cord pass from the sacrum through the pelvic cavity and down into each leg. Blood vessels also pass through. The pelvic cavity is crowded and complex. Dr. Jerome Weiss, author of Breaking Through Chronic Pelvic Pain, A Holistic Approach to Relief, says that Western medicine has failed IC and chronic pelvic pain patients because specialists rarely look beyond their specialty. Urologists focus on the urinary tract, gynecologists on the reproductive system, gastroenterologists on the gut, physical medicine specialists focus on muscles and bones. Rarely do these specialists consider how these structures influence each other. We know, for example, that organs can change muscle behavior. If the bladder is in pain, perhaps from an infection or chemo, the pelvic floor muscles will get tight to stabilize the area and protect the tissues. This is known as the viscerosomatic or guarding reflex. The therapeutic priority for this patient is to calm and soothe the bladder, which then should allow the pelvic floor muscles to relax. But what about those patients whose IC symptoms began after having a fall or having a baby? Can muscle dysfunction change the bladder and the other organs? Yes. Injured muscles often become tight and develop trigger points, which interfere for long periods of time with blood flow and nerve function. This somatovisceral reflex can lead to dysfunction in the skin, the bladder, and other areas of the pelvis. And the therapeutic priority for this group of patients is to restore blood flow and nerve function by restoring good muscle health. Today, we no longer suggest that every patient with frequency, urgency, pressure, or pain has bladder disease. In fact, the top pelvic pain specialists in the world now use phenotyping to create an individualized diagnosis and treatment plan. But this is new, and few local doctors will be familiar with this concept. Thus, it's up to the patient to learn more about it and perhaps request a more comprehensive diagnostic workup. In 2015, Dr. Christopher Payne proposed 5 subtypes for IC based on his experience treating thousands of patients. Though Dr. Payne's proposal represents a progressive step forward, it's important to know that as far back as 2007, others were considering the benefit of breaking IC BPS into different subtypes. The European Society for the Study of IC, known as ESSIC. In 2007, the European Society for the Study of IC was the first to propose types of IC. Their system requests physicians to rule out other conditions: chlamydia, ureaplasma, mycoplasma, corynebacterium, mycobacterium, tuberculosis, candida, herpes, and human papillomavirus. They also screen patients for pelvic floor dysfunction, pudendal nerve entrapment, a history of radiation, chemotherapy, urinary retention, stone disease, and more. Unlike the USA, they require patients to undergo a hydrodistension with cystoscopy to look closely at the bladder wall and perform a biopsy. Pathology results in bladder wall health are then rated using a simple system. Numbers 1 to 3 indicate the severity of the bladder wall. ABC indicates the severity of the biopsy results. So a patient with a normal bladder wall and biopsy results would be diagnosed with BPS IC 1A. A patient with lomulations with an inconclusive biopsy would receive a 2B rating. Then a patient with Hunner's lesion and biopsy results showing inflammation would be rated 3C. The Essex system, subtyping system, is in use throughout Europe, but of limited value in the United States. The US IC guidelines do not support the use of invasive testing unless the diagnosis is in doubt. In Europe, only patients with Hunner's lesions are diagnosed with interstitial cystitis. The remaining patients are diagnosed with bladder pain syndrome. U-point and input. In 2009, the U-point system was developed by Dr. Dan Shoskis at the Cleveland Clinic and J. Curtis Nicol at Queen's Hospital in Ontario. It asks clinicians to assess pelvic pain patients in 6 specific domains: bladder symptoms, organ-specific findings such as the presence of Hunner's lesions, the health of the pelvic floor, the presence of infection, the presence of any other neurologically related conditions, and catastrophizing and/or depression. Using these findings, physicians then create a customized treatment plan for their patients. The system has been validated in multiple research studies and is a foundation for the Canadian Urogynecological Association guidelines for IC. In 2017, Crane, Lloyd, and Shoskis adapted U-point for the IC patient by creating the input system. It asks clinicians to evaluate just 5 areas: the presence of infection, the presence of other neurologically related conditions, psychosocial symptoms, the presence of ulcers, and tenderness of the pelvic floor. It too has been validated in at least one research study. The Dr. Chris Payne system. In 2015, Dr. Chris Payne argued that a diagnosis of IC does not provide the doctor or patient a clear, intuitive treatment pathway to the most effective treatments. He suggested that the IC diagnosis be made more specific using 5 potential subtypes. In the pain system, he applies the name of IC to the presence of lesions. All of the patients are diagnosed with bladder pain syndrome. So IC subtype 1, Hunner's lesions. Researchers around the world agree that this is the easiest group to identify because lesions, aka Hunner's ulcers, are visible on the bladder wall and known for causing severe pain and for bleeding profusely during hydrodistension. Pathological studies show severe chronic inflammation at the site of the lesion, as well as a deterioration of the bladder surface. While the cause of lesions is still under considerable debate, different research teams have linked 2 viral infections to lesions, including the polyoma BK virus and the Epstein-Barr virus. Both herpes and the HPV virus have also been found in the bladder, though not linked to lesion development. If a viral infection is the cause of lesions, this could explain why these patients rarely respond to traditional bladder treatments, but they do respond well to lesion-specific treatments: laser therapy, fulguration, steroid injections, and hyperbaric oxygen therapy. A new medical device, Lyris, made by Allergan, is the first treatment in history to heal Hunner's lesions and reduce their size and quantity after just a 2-week treatment. Unfortunately, it has been deprioritized by Allergan and is no longer available. All right, bladder pain subtype 2, bladder wall driven. Patients with bladder wall injury and/or dysfunction have discomfort as their bladder fills with urine that is relieved by urination. Chemical injury is the most common cause of bladder wall damage. When exposed to harsh chemicals like chemotherapy or ketamine, the integrity of the bladder wall can be physically damaged, allowing urine to penetrate deeply into the bladder wall. The long-term consumption of coffee, tea, soda, and/or the use of artificial sugar may irritate bladder tissues as well as nerves and mast cells. For these patients, bladder healing begins when the chemical exposure is reduced or eliminated, a not-so-easy challenge for patients who are addicted to caffeine. The urinary tract can become chronically infected with bacteria, fungi, and viruses. While acute infections are maybe easily to identify with traditional urine testing, chronic infections are often more difficult to isolate. New next-generation DNA urine testing has provided a wealth of information for patients and providers who wonder if a chronic fastidious bacterial infection could be the root of their discomfort. And if pathogenic bacteria are present, next-gen testing can identify antibiotic-resistant genes and recommend targeted antibiotic therapy. Long-term antibiotic therapy is no longer recommended as an IC treatment by the American Urology Association. But fungal infections may also be the culprit. The MAP Research Network recently found an overgrowth of candida in the urine of patients who were struggling with IC flares. Subsequent studies have found several species of fungi, and the more fungi present, the greater the pain and discomfort. Unfortunately, typical urinalysis does not identify fungi, but next-generation testing can identify several fungal species. Viral infections of the bladder have minimal research funding and steady results. In the past few years, studies in Europe and the USA have found polyoma, herpes, HPV, and Epstein-Barr in some IC patients. Antiviral treatment may be suggested, but there is no consensus on the appropriate diagnostic nor treatment methods for this subset of patients. If symptoms began after hysterectomy or with aging, the genitourinary syndrome of menopause must be considered. The bladder relies on a thick coating of mucus to protect the cells of the bladder wall from irritants in urine as well as bacterial infection. Unfortunately, mucus production is estrogen dependent. Younger women usually have thick, robust mucosal barriers when compared to their older relatives. With a much thinner coating, older women struggle with a more sensitive and easily infected bladder wall. Topical estrogen therapy is often recommended for this group of patients. Once infection has been ruled out, the treatment is focused on calming and soothing the bladder wall. The AUA suggests that patients begin with the least invasive therapies first. Self-help strategies such as diet modification, increasing water intake are essential, and some over-the-counter supplements, Bladder Builder, Bladder Rest, Cystomed, Cystoprotect, Allopath, may provide a bladder coating effect. If supplementation does not work, urologists will turn to traditional medications. Elmeron, the only FDA-approved oral medication for IC, also provides a coating effect, but has been linked to serious eye disease. I'll come back to that, Laura. Oral urinary analgesics, pyridium, azo, bladder pain relief, provide a short-term numbing effect. Patients with a history of allergies may benefit from the use of an antihistamine. Low-dose antidepressants may help calm hypersensitized nerves in the bladder wall. Bladder installations can provide a coating and numbing effect. And if additional help is needed, Botox injections and neuromodulation can be explored. Patients should remember that the human body is programmed to repair tissue over time. It may take months for the irritation of their bladder wall to improve and/or resolve. Should that patient be exposed to a chemical irritant or infection, the cycle may begin again. Okay, BPS subtype 3, pelvic floor driven. Many women and men report that their symptoms began after a pelvic trauma, childbirth, tailbone injuries, falls, hysterectomy, or other pelvic surgeries. A history of sports such as ice skating, gymnastics, football, wrestling, motorcycle, or bike riding is a well-known risk factor. Sexual trauma and abuse can also play a role in muscle dysfunction. While the symptoms are remarkably like subtype 2 with frequency, urgency, pressure, and/or pain, there are subtle differences. Because the pelvic floor muscles are tight, patients often find it difficult to start urination. They may feel heaviness or pressure in their pelvis. Some report a downward sensation as if something is falling or being pulled out of their pelvis. Others may feel as if something is being pushed up inside their urethra, vagina, or rectum. Muscles that are working hard, tight muscles, produce lactic acid, which can cause a burning sensation in the vagina, rectum, glutes, leg, or lower back. Weak muscles may begin to flutter, spasm, or vibrate. Many of these patients have spent months or years on bladder therapies with little effect. Irritating foods may not play an integral role in this subtype, though sex and other activities that can impact muscles can trigger painful flares. Obviously, these patients benefit from myofascial therapy, including yoga, stretching, and pelvic floor physical therapy. Muscle relaxants, baclofen, Flexeril, vaginal Valium may be helpful. Trigger point therapy, or Botox injections into muscles, and neuromodulation may also be helpful. BPS subtype 4, pudendal neuralgia. Pudendal neuralgia patients struggle with nerve dysfunction, often due to muscle tension, trigger points, or injury. Sharp electrical sensations in the pelvis or on their skin. Pain that shoots down one leg, sciatica, is common. A buzzing or vibration sensation can also occur. Symptoms are often positional in nature. Patients may be fine when they stand, but have extreme pain when they sit down, bend over, or squat down. They may sleep well, only to trigger a day's worth of pain when they sit on the side of their bed. Persistent and painful genital arousal, PGAD, can occur when the pudendal nerve becomes irritated or inflamed. Nerve trauma can occur after various injuries, such as prolonged bike riding or a complication related to mesh surgeries. Treatment focuses on calming and soothing nerves. Patients are instructed to stop any behaviors which trigger pain, such as sitting for long periods of time. Yoga and or stretching may help reduce muscle tension, as well as myofascial physical therapy. Topical anesthetics may be used if the skin shows signs of sensitivity. Over-the-counter supplements that contain palmitoyl ethanolamide may calm neuropathic pain, such as Peora, Bladder Builder, or Allopath. Pudendal neuromodulation or nerve blocks may help calm nerves, and in rare cases, patients may require surgery to release any compromised nerves. And BPS subtype 5, central sensitization syndrome, chronic overlapping pain conditions. If you have relatives who also struggle with sensitive bladder or gut, you are not alone. Research studies have shown that some patients have relatives who struggle with IC and its related conditions. They may have other chronic overlapping pain conditions such as IBS, vulvodynia, fibromyalgia, prostatodynia, and TMJ. Panic disorder, catastrophizing, bladder problems, thyroid dysfunction, mitral valve prolapse have been linked to some families due to a variation of chromosome 13. Trauma and post-traumatic stress disorder may also play a role in altered pain processing. Central sensitization syndrome patients usually have more sensitive nervous system, including very sensitive skin, drug sensitivity, food sensitivity, smell sensitivity, chemical sensitivity, and even visual or sound sensitivity. In 2018, the MAP Research Network released a study which identified 4 levels of sensitivity in IC patients. Global sensory sensitivity, characterized by a sensitive sense of smell. Bladder hypersensitivity, as the bladder fills with urine. Pain in different regions of the body, and chronic overlapping pain conditions. Patients who struggle with chronic overlapping pain conditions appear to have an underlying central nervous system pain processing disorder. Numerous studies have found that certain areas of the brain are bigger and abnormally amplify pain sensations. This may explain why some IC patients have bladder pain but no visible tissue injury. Researchers are trying to understand how and why the nervous system changes. Genetics may play a role, as well as childhood injury. Small fiber polyneuropathy may also be involved. In this subtype, Dr. Payne emphasizes that patients with multiple pain disorders or central sensitization should be treated differently than patients with other bladder or pelvic pain. He discourages the use of invasive therapies that could trigger more pain and make their condition worse. The goal of treatment is to calm and soothe the entire nervous system. Most patients have already begun this process by removing chemical irritants in their homes and lives. They may be more comfortable living and working in a quieter country environment rather than a loud city stressful environment. Self-help strategies that calm the nervous system, such as relaxation, meditation, improved stress management skills, anxiety management, cognitive behavioral therapy, are essential. Traditional therapies such as amitriptyline and gabapentin may also be used. Thus, we come to the chicken versus the egg dilemma. In reviewing the pain subtypes, many of you may be saying, but I have more than one. It is possible to have more than one subtype. Generally, one is usually primary while the others are secondary. I call this the chicken versus the egg dilemma. Which comes first, the chicken or the egg? In our case, it's which comes first, the bladder, the pelvic floor, or the nervous system. Most patients will have bladder and muscle dysfunction because they are so intricately connected. The missing link, however, may be the presence of nervous system dysfunction. An important goal of therapy is to calm and soothe those hypersensitive nerves. So in conclusion, the subtypes discussed are the most effective in a clinical setting. They help patients understand the many potential triggers for their pain, reinforce the importance of a proper pelvic floor assessment, and of course, multimodal therapy. It breaks my heart when I work with patients who have never understood the influence that their muscles, hormone levels, and nerves can play in their bladder symptoms, often resulting in years of unnecessary suffering. The IC and chronic pain research movements are vibrant and dynamic. At the 2020 annual meeting of the American Urology Association, several new studies were presented. Hunner's lesions are now considered a separate disease. The Finding a petechial hemorrhaging and glomulations is no longer relevant, as we've learned that the test itself can cause these to occur. Dr. Curtis Nickel gave a fabulous lecture on the role of the urinary biome and how devastating long-term antibiotic therapy can be to the many good bacteria found in our urinary tract and gut. He also predicted that next generation DNA urine testing will quickly replace traditional urine cultures because it is far more accurate. You can also expect to see more or less proposed subtypes in the future. But for the moment, Dr. Payne's system has been a fabulous new resource for patients and practitioners. Signed, Jill Heidi Osborne. I read that and go, girl, you were on that day when you wrote that. Laura says, can a very low dose of ketamine exacerbate bladder pain? Yes, absolutely. Ketamine acts, and I was working with another patient who was using ketamine like 2 weeks ago. We do the only ketamine support in the country here at the IC Network. So ketamine is an animal tranquilizer. And so when your cat or dog goes in for a minor procedure, and when they wake up, they're walking in circles and you don't know where they are, that's ketamine. Ketamine causes what we call a dissociative high. You feel like you're floating. Ketamine has replaced heroin as a drug of choice throughout the world, in part because it's so inexpensive. The problem, though, is that, I was just watching, literally last night, I like watching those customs videos on YouTube where they're going through people's suitcases to see what they're trying to bring in. And this lady had 5 shampoo bottles and a bunch of tubs all filled with ketamine. So ketamine is a very profitable drug that is often spliced into ecstasy. It's distributed throughout the world, and it's devastating. So here's the issue. It acts as an industrial solvent in the bladder, in the urinary tract. It actually damages a lot of the body. And I have a website called ketaminecystitis.org that you can go look at. And I've got all the research, except for the last year or two, all the research that has established that. Ketamine cystitis was first documented in Canada, and then they documented it in England, and they surveyed every urologist in England, the United Kingdom. Every single urologist in the United Kingdom was treating ketamine cystitis. That's how pervasive this is. So ketamine ideally is used for end-of-life care. For that patient who's dying, who is in agony, where we're just trying to ease their journey, ketamine makes sense. More recently, in the last 10 years or so, they found that low-dose ketamine also appeared to help with pain processing a little bit. And so some clinics are now incorporating very low-dose ketamine into their pain protocols. But if you develop bladder symptoms while using ketamine, then it's just too much for you. You might have to back off, and you certainly have to talk to your doctor about it. A good example of ketamine is called what's it called? They can do a compounded ketamine cream with, it's kind of like the Omnivac cream, which you use with vulvodynia. So they have a cream that might have a little bit of ketamine, a little bit of muscle relaxant baclofen, a little bit of amitriptyline to try to calm those nerves down. Yeah, Laura says, used for improved cognition after a vaccine reaction, but thanks. Who was it? If you have read Prince Harry's book, Spare, and I did, I like to listen to books. I love listening to books. So I always have a book on every day, pretty much. His book, Spare, is fascinating. because it's not a spoiled rich kid saying, woe's me. This is a young man who grew up in extreme circumstances. His earliest memories are being chased by the paparazzi and the click of cameras. And when his mother died at the mercy of paparazzi, you guys realize that when Princess Diana was killed in that car accident, the media were chasing them. They ran up to the car, and instead of helping her, they took pictures of her dying. Lots of them. And so from that moment, Harry became a trauma patient. And it changed him profoundly. He developed severe anxiety disorder, severe panic attack. And his trigger is cameras clicking. It's cameras clicking. And so it describes kind of like he went through a point where Willie, his brother, he called him Willie, wanted to talk about it and went to him, but he couldn't talk about it. They never came together at the right time to grieve. For Harry, he buried it all. He just literally buried it all. He simply couldn't talk about it. He only cried once. And do you know that when his father told him his mother had died, he didn't even get a hug. He got a pat on the knee. Can you imagine? And then the trauma of walking behind his mother's coffin, that was just terrible. And he said they all now admit should never have happened. Those young boys should not have been placed as a public spectacle like that. The harm was immeasurable. So anyway, he doesn't get help. I mean, he gets little bits of help here and there, but nobody ever really gets to the bottom of it until Megan. And he was dating Megan, and she was making dinner or something, and he said something very mean to her, like cruel. And she stopped and turned to him and looked at him and said, "You may never speak to me this way again, ever." But then she said, "Why are you angry? Why are you angry? Why is this anger coming out? What is this?" And that, a desire to protect his wife and his family, was what drove him to getting help. And he has done extensive therapy. And when you read his book, this is a very smart young man who has done a lot of work. It makes me want to go back to therapy, because I know I have things that I would like to work on too, like how to grieve, caring for elderly parents. I'm so impressed with that. But he actually, with the help of his doctors, because he was really having trouble, man, he was just locked down tight, just a little tiny boy inside of his brain, just frozen in grief. So he did, with the help of his doctor, some hallucinogenic therapy like ketamine. And that's what broke it open. That's what broke that last little but agonizingly painful memory trauma. That's what got him through it. And so there can be a place for ketamine, but as he said, under very, very close medical supervision. And in our magazine, so my next IC Optimus magazine, which we're putting together right now, is on trauma and how that manifests in the IC patient. And I've got Dean Tripp from USC, or the chairman of that division of the MAP Research Network, is doing a massive interview. He's working on it right now. I should have it in a week. And I've got Cleveland Clinic gave me permission to reprint a fabulous article that they did on trauma. And I just feel like for those of us who have a history of trauma, because I do too, like I'm so comforted that we understand context now. We understand the toll and the effect of trauma, especially in children, and how that affects them their whole life. And, it's always interesting when somebody new calls and they're getting a new diagnosis or they're struggling to find care, and we go through the subtypes, and it's like, okay, do you have super sensitive skin? Yeah. How did you know? Do you have a weak sense of smell? Yeah. How did you know? Well, I do too. Do you struggle with anxiety disorder? Yeah. How did you know? Well, I do too. Then, and then we give them context. Why does this happen? Why does this happen? Well, that's because there's a history of trauma. I mean, that's what the research shows. And for 80%, it's physical trauma, and for 20%, it's emotional trauma. And it's always, for the 30-year-old or 40-year-old who's been in anxiety. I was working with one lady who literally, she could have been my twin, only she was 20 years younger, but she was hiding. She was just hiding from life. She was hiding because of the trauma. And I just think that we have to hold our hands out to each other, and love on each other for, listen, we made it. You made it this far. As I love to say, you are a tough bitch. And there's a great offense when somebody says you just have to let it go. Well, you can't let go how the trauma hardwired your brain. But and as Harry so artfully pointed out in his book, but we can't live in the past. And this is, if you find yourself living in the past, if you find yourself repeating over and over that image of that person hurting you. And I've got one, well, I've got two. One I've forgiven. The other I have not forgiven. I don't know if I will try. I don't know if I will ever be able to forgive. But they don't deserve another minute of our time, for God's sake. We made it. Despite the greatest of odds, we made it. We are here. We are alive. And yes, we've got some issues, but what happened to us will never happen again, because we are truly one day older and one day wiser. I will never let somebody abuse me the way I was abused. And think about what Megan said to Harry. You will never, ever, ever talk to me that way again. She drew that line. Now, that's real hard when you have an abuser at home who will slug you, when you say that. That's real hard. It is a tragic fact that women and many men are abused to the degree that we've been abused. I have shared that, now granted, I'm 62, I'm going to be 63. When I grew up, all my girlfriends had been raped, all of them. And that's happening in the Middle East all the time. And for the girl who's raped, she's the one who's punished, the child, you know. So women, stand up. Let your voice be counted. Don't let anybody take your rights away. We are a hair's breadth away from giving men control over us, and that's not going to work. We have fought for decades for the right to vote, for the right to autonomy, for the right to fair wages, fair income. And if we don't stop what's happening now, that could happen again. Nobody's going to tell me what to do with my body. Period. End of story. You can shut the F up. This is my body. This is not your body. You don't get to tell me what to do with my body. So I hope that you will join me in rising and helping to stand for protecting those who have been hurt and helping people become strong, empowered, and all that sort of good stuff. Hold on. Renee says stuffing this trauma down never works. Yeah, it doesn't. It doesn't. I smell something cooking. That's always dangerous. Give me a quick sec. Hold on. Somebody cooking something? It's toast. Okay. Somebody made toast and didn't burn it. That's a win. You give a toaster to a 100-year-old and a 93-year-old, you never know what's going to happen. There's nothing worse than having every smoke detector in the house go off. Okay, Phyllis says, I feel so bad. My youngest, 35, was born with eczema. She comes over and will not eat off our plates because she says they stink. Always wash in our dishwasher, no smells to anyone. Should I be more compassionate? Phyllis, absolutely. If, like, for me, I can only use one dishwashing soap and not smell or taste anything. I can't. We used to use Ivory. If I wash my dishes in Ivory, I smell it and I taste it. If I wash a pan in Ivory and I make eggs on it, I taste the Ivory, even though it's completely rinsed off. Her nervous system is wired, and she can't change that. She literally can't change that. She'll never get over that. It is how she is wired, just like it is how I am wired. And so you must be compassionate about her sensitivities. But most importantly, Phyllis, here's the deal. I know that there's a part of you who feels like it's your fault. Stop it. Stop it. It's not your fault. But you know, parents, and I speak because of my own parents' experiences with me. I mean, they felt really bad about what happened to me, but they had no control over that. They couldn't physically change that. And I don't want them to feel any shame or blame about what happened. It is what it is. It happened. It's over. It's done. But the reality is that her nervous system is physiologically more sensitive, and she cannot subconsciously or consciously turn that off. And so you need to ask her what dishwashing soap she uses, and you need to use that and really respect that. And the same is true with laundry detergent. The same is true with fabric softener. I can't have any fabric softener in my home at all. At all. And the only dishwashing soap I use is 7th generation free and clear. I mean, laundry soap, 7th generation free and clear. You can't do any Glade plugins. You can't do room sprays. You can't do bathroom sprays. The only spray that I can get away with is this one, which is a Mario Badescu. I can get away with these. It smells good. But anything that with petroleum in it, you know, again, oven cleaner, anything like that just doesn't work. So Renee says, amen, sister. Hell no. Thank you, hun. Thank you, Laura. Renee says, car exhaust chokes me. Yeah, you know what I have a genuine fear over is Christmas trees. I am so sensitive to pine. I have gotten so sick from live Christmas trees. Even going to church, sitting at the back of the church with a Christmas tree up on the altar. Oh, I'll have a migraine. So we all just have, we all have our own unique sensitivities. And rather than fight them, we just embrace them. Like, okay, it is what it is. I don't eat chocolate. I don't eat oatmeal. Those are two things I'm really, really sensitive to. But now I'm also sensitive to spinach and lettuce, leafy greens and kale. I don't eat those. And if I don't eat those, I'm good. If I eat those, I'm gonna suffer for a day. So it's about finding what works for us. And also just being really careful with new furniture. Again, the Lazy Boy debacle was just, I walked into Lazy Boy, I needed a new couch and a new chair. And first thing I said to sales guys, I need something that's not treated. You can't do any treatment to this. I am sensitive. And I'm not just sensitive, I am over the top. Oh my God, I'm going to die sensitive. My nervous system was hurt. I'm an injury patient. And that sales rep said, not a problem. We can definitely do that. Oh, what a load of shit. So I picked it out. And then I said, because hello, chemist here, I knew about gassing off. And so I said, okay, once I order it, I want you to put it in your factory. Or I want you to put it in your local warehouse, take the plastic off and let it gas off for a couple of weeks. Just let any residual chemicals, just let it go. And they're like, not a problem. Not a problem at all. Order it, pay a couple $1,000. I get it. I was doing errands. My parents let him in. It was wet with Scotchgard. It was wet. And I was just hysterical. I literally had to get plastic. I sealed off the room from the rest of the house. Nobody could go into the room. I had fans in the windows, and the shit hit the fan. And I called the company and I said, what the hell did you bring into my house? What did you bring into my house? This is not what I ordered. And they went, ma'am, this is what you ordered. And I said, it was not to be treated. I can smell the Scotchgard. And then it's like, did you at least unwrap it and let it gas off? Oh, yes, ma'am, we did. No. They lied because the warehouse guy told me they lied. He said, no, Ms. Osborne, we didn't do that. We literally unwrapped it an hour before we delivered it. It was wet. So, I will never buy anything from Lazy Boy again. I just simply can't trust them at all. Life, right? That's what it's like to be sensitive. My sister got a couch. She's like, yeah, it smelled for a couple of days and it was fine. It's like, no, it was torture for me. John says, I have multiple extreme chemical sensitivities. The most common problem is severe bladder pain from meds. I would assume it's a common filler. How would I determine what it is? I think, John, what you're going to have to do, so like the best example I can give you is hydroxyzine. So hydroxyzine comes in two chemical forms, hydroxyzine hydrochloride, also known as Atarax, and hydroxyzine pamoate, also known as Vistaril. The brand name is not available anymore for Atarax. It's all generic. And generics are filled with the cheapest fillers they can get. And so Atarax is notorious for causing sensitivity reactions for people. I took one Atarax and I knew immediately I would never be able to take it. I don't remember what the reaction was, but it was strong. So I called my doctor. He is like, okay, let's switch you over to Visceral. Visceral, which comes in a capsule, is much cleaner and purer. And so Visceral, so I had no problems with the Visceral at all. So sometimes, so number one, I would really differentiate between generic and brand name meds. You pretty much have to assume that the generics are going to have cheap fillers in them. And then it's about comparing ingredients. That's the only way to do it. I mean, the only other example I can give is with thyroid pills. So like, I was on Synthroid originally, and then a new one came out. It was a generic. I did it. I was actually fine with it. Did it for like 5 years. And then that company went out of business. And so I switched to another generic, and my hair started to fall out like in chunks. I call the pharmacy. It's like, why is my hair falling out? They go, yeah, people are complaining about that with this new thyroid. Yeah, get me off of it. And I just had to go right back on the brand name Synthroid. So generic medication, especially a lot of generics are made in China, so. And the same is true with supplements. I mean, with the supplement companies that I work with, and Natural Approach Nutrition is my preferred company right now. They have assured me their attention to product quality and detail is second to none, and their goal is nothing from China. The hard part is that there are some ingredients only made in China. So, like, I think one of the vitamins in the in the Bladder Smart, there's no choice. It has to come from China. But anything that comes from China gets double or triple tested just to make sure. So with other supplements out there, especially a lot of the cheap supplements, do you know, like canned peaches? Come on, canned peaches, Dole canned peaches. Big chunks of them are coming from China now. No, I'm sorry. I'm not going to willingly eat anything from China right now. I don't. In China, it's legal. They can call something organic, even if it's grown in soil that's contaminated with heavy metals and toxins. And 60 Minutes did that expose years ago. So I do everything that I can not to consume things from China. I think they said that pretty much every river in China is close to dead because of all the toxins from the factories that have been allowed to flow into the rivers. The biggest river in China is completely dead. And that river water is being used to water these crops. So, no. Now, I could be wrong. Somebody might pick that apart, but that's just my perception of it. Anyway, all right, my friends. Since you don't seem to have any more questions, I will go grieve with the rest of the 49ers fans at their defeat today. I wish you well, and if you find these meetings helpful, please come on over to our website and sign up for our free newsletter. Emphasis on free. And or you can become a member and receive our magazine, but that is $25 a year or $50 a year, depending upon what you pick. All right? So be well. I hope you sleep well tonight. I hope you sleep well this week. Working together, we're going to get through it. All right, guys. I will. And somebody said here, hold on a sec, Renee said, the last time I remember not worrying was the age of 7. Yeah. I get it. Renee. And hold on. Somebody else said something I wanted to acknowledge. Amy, about who ruined social media. Exactly. Nailed it. All right, my friends. I will see you later. Be well. I don't know. Can I turn both streams off at the same time? Let's see if I can use my left hand and my right hand at the same time. 1 2, 3.